Good morning. Welcome to day 3 of the 6th International Pediatric Hematology Conference. Over the past 2 days, we've witnessed the groundbreaking discussion, research, and collaboration that highlight our shared commitment to advancing pediatric hematology and improving children's life globally. Today, we continue building upon key themes: innovation in diagnosis and treatment, equity in healthcare access, and empowering future clinicians and researchers. A heartfelt thank you to our organizers for making this virtual event possible. Let's make day 3 as impactful as the days before and continue working toward a brighter future for children worldwide. Thank you, and let's begin. So our first speaker is Dr. Mariam Abusil, is a consultant medical genetist at Salmania Medical Complex, Bahrain, since 2018. She completed a 2-year fellowship in medical genetics, focusing on clinical genetics and metabolic disorders at King Faisal Specialist Hospital in Riyadh, Saudi Arabia, where she graduated top of her class. Additionally, she completed a clinical attachment at the Manchester Centre for Genomic Medicine, St. Mary's Hospital, UK. Please, Dr. Mariam.
Well, good morning, everyone. Thank you, Dr. Najat. I will just share my slides. Okay, my voice is clear to everyone, hopefully. And is my slides clear, can be seen, Dr. Najat?
Hello, doctor. We cannot see your slide.
Because it's...
You just double click, it's open at your end. Yeah, it's open now. Just you can put slideshow.
Now, I kept it on slideshow.
Clear, we can see it.
Okay.
Go ahead, please. You can start.
Okay. So thank you, Dr. Najat. Good morning, everyone. Because I'm unable to see it now. It is showing for me your side.
Mariam, you're okay. Please start. We can see your slides. Start now.
Yes, because Dr. I'm trying to see mine. I'm trying to keep it in my view. Because I can't see it.
We see at our end. You can stop sharing
Yes.
and share it again, please.
Okay. Okay, now I can. Okay, so it gives me great pleasure to be presenting today in the 6th Pediatric International Hematology Conference. I would like to thank the organizers committee, and without any further delay, I will move on to start with my presentation today with regards to osteopetrosis. Why is it important to understand this condition? It is very vital due to its significant clinical implication and the insights it provides into bone biology. Early recognition of this condition can really improve the patient outcome through timely intervention. I don't have any conflict of interest and no financial disclosure. So the word osteopetrosis derives from the Greek word osteo, meaning bone. Petros means stone, and osis means any abnormal condition. So it defines a genetically heterogeneous group of diseases which are mainly affecting the skeletal tissue. And its severity can be ranging from benign to really fatal condition in early fetal childhood. So it was first described by a German radiologist by the name Albert Schönberg in 1904. Let us first understand the pathophysiology behind this disorder. So normally we have two types of cells when it comes to bone. There are something which we call as special cells called the osteoclasts. So these work on small areas of the bone, consistently being broken up by these special cells, which are called as the osteoclasts. At the same time, they are being built again up by other type of cells called as the osteoblasts. So this is what we call as bone remodeling, and it is very important that these two type of cells work on to keep the bone healthy. So what happens in osteopetrosis is these osteoclasts are abnormal and cannot break down the bones, whereas the osteoblasts, they continue making up the new bone. So the bones will be thicker in nature, but unfortunately, they are of unhealthy type. So here is where we need the osteoclast. The osteoclast, they originates from macrophages or monocytes, and then they start differentiating till they become the well-formed bone-resorbing osteoclast. They work on certain areas or pits on the bone surface, which we call them resorption bays, or other name, Hauschips lecula. And they work by acidifying these areas. So when these are working up, the bone will be broken in these areas. So what happens in osteopetrosis? Because of gene disorders in around 8 different genes, this will be working and the bone resorption will not be very well organized. And again, as we mentioned, the osteoblast, which is the building bone cells, will keep on working. So osteopetrosis, otherwise other name for it, is also known as the marble bone disease. Its prevalence, there are different genetic types, inheritance according to the mode of inheritance. The malignant type is the autosomal recessive mode of inheritance, and its prevalence is 1 in 200,000 cases, individuals. Whereas the milder form, which is the autosomal dominant form, is more common. It is 1 in 20,000 individuals. And we have also an intermediate form, which is also of an autosomal recessive inheritance. And rarely they have also mentioned an X-linked type of recessive osteopetrosis. One very important one should keep in mind, especially when we talk about autosomal dominant mode of inheritance. When we say autosomal dominant, means one allele mutation is enough to cause the disease, whereas in autosomal recessive disorders, we are talking about 2 allele mutations. So when we talk about autosomal dominant, there is something called as penetrance, where you might be having it as a genotype as in the gene, but maybe you are manifesting it from mild to moderate to severe. So they might be skipped generations. So sometimes it may be skipped in, and you will not be noticing it in certain generations where it appears more severe in other generations. So we mentioned that there is around 75% gene penetrance when it comes to this disease. Genetics. So there are 8 different genes which may be connected with osteopetrosis, and it is mainly affecting the chloride channel dysfunctions or the carbonic anhydrase enzyme function. So one of the genes, that is the CLCN7, which is related to the chloride chain gene, accounts for around 75% of the autosomal dominant form of this disease, whereas it accounts for around 10 to 15% for the autosomal recessive form of it, and also accounts for majority of the intermediate form. So this gene encodes one of the subunits of the chloride selective ion channel, which is located on the surface of the osteoclast cells, and which we mentioned, the function of it is to break down the calcium salts that make up the bone tissue. Other gene which is very commonly associated with osteopetrosis is the TCIRG1, which is related to the T cell receptor. There is other different type of other genes which are also associated, keeping in mind that still 30% of all the cases of osteopetrosis, the cause might not be identified. These are the genes, and there is a study where they try to find the how much it is affecting the manifestations. For example, the one which we mentioned related with autosomal recessive disease, the TCIRG1, is usually often very severe, with severe hematological manifestations and other clinical manifestation that we'll be talking about. So usually it is one of the genes indications to undergo stem cell transplant. And these are the other genes which are associated with it. So let's go to the most important part. How does this disease manifest clinically? Number one, we will go to the autosomal recessive form, which we said is usually the malignant form, which is usually a very severe form. So number one, they might manifest with frequent fractures. So if we go back, we mentioned that these bones are usually thick bones, hard. They're supposed to be hard bones. But despite the increased bone mass, these bones are brittle and prone to fractures. And it is especially noticed that the fractures are more commonly seen in the long bones, especially the femur, tibia, and the humerus. And it is seen more commonly when it is related to the long bones, then the lower extremities, then the upper extremities, then the axial skeletal system bones. So the lifelong prevalence of fracture is around 40 to 50%. And because they are brittle, they are very prone that there will be delayed healing, delayed union or malunion or cause malunion of these fractures. And unfortunately, because of the type of these bones abnormality, sometimes it will be really very difficult to correct them surgically because of the difficulty in the drilling or the screw placement, or increased risk of even iatrogenic fractures. Other also common complications of it is the cranial nerve palsy. Again, because of the increased bone density and the abnormal bone growth in osteopetrosis, this might lead to narrowing of the foramen through which many of the cranial nerves pass through. So this compression of the cranial nerves might lead to different cranial palsies. So the commonly affected nerves include the optic nerve, the facial nerve, and the auditory nerve, which will lead to either visual impairment, facial weakness, as we can see in this picture. This is an example of a case with osteopetrosis, having facial palsy, or might even cause deafness. So going to the order of the most commonly involved genes, it is the optic, auditory, trigeminal, and the facial. So we mentioned that one of the complications of this disease is the progressive deafness, blindness, or different other cranial nerve palsies. Again, because of the abnormal, and we know that because of the bone, there is the bone marrow inside it, and because of the abnormal morphology, there will be even bone marrow infiltration. And this would lead to different cell lines depression, which is we call as the pancytopenia. So if the low in the hemoglobin line, it will cause anemia, which will be manifesting as fatigue, pallor, dyspnea, syncope attacks. Okay, or also they will have abnormal morphologies because of the extra medullary hemoptysis, which is trying to replace the anemia. The thrombocytopenia will be causing increased risk of bleedings. There will be petechiae, there will be purpura, and again, as we mentioned, increased risk of bleeding from different sides. And if the WBC line is involved, they will be causing leukopenia with increased risk of infection. Other symptoms which may be associated with this disease is the chronic nasal congestion because of the narrowed sinus cavities. They'll be complaining of chronic pain. They are risk of developing osteomyelitis. Some of them also might manifest with CNS manifestations in the form of intellectual disability or even intractable seizures, especially if they are affecting their calcium levels. And even with the hypocalcemia, they might have also having increased irritability. And other also symptoms like carpal tunnel syndrome. What we will be seeing or observing while physical examination, again, we are talking about the severe infantile form. So when they're born, they will always have, we will notice that their head circumference is above the normal. So they will have relative macrocephaly. They will have short stature. They will have hypertelorism, means increase in the interpupillary distance. And because of the bone abnormalities, they might have exophthalmos, that is, there will be protruding of the eyeball, squint, nystagmus. They will have hepatosplenomegaly, again, because of the compensatory extramedullary hemoptysis. The infantile cortical hyperostosis of the mandible, and especially also in the clavicle, ribs, and scapula might be noticed. And also always keep in mind that to always have a dental inspection, because these cases are prone to have multiple dental abscesses. And actually most of the cases, I always notice if they have genetics abnormalities related to the skeletal, always the dental is a part of it, as a part of the symptoms, the dental involvement, and it might be in the form of losing multiple teeth or dental abscesses. So the life expectancy, if they, with the, especially the complication of the bone marrow failure, the recurrent infections, which can be sometimes very fatal, some babies with infantile osteopetrosis may die even before 2 years of age. And they have seen studies that without treatment, majority will die by the age of 10 years. When we go to the autosomal dominant form, we mentioned that it is usually less severe, that sometimes it can be easily missed. So they can come with fractures, which is pathological fractures, anemia, joint pain, lower back pain, or early hip osteoarthritis. But on physical examination, sometimes it will be difficult to pick them up because they will have normal height and appearance. But when we take an X-rays, we will notice that there is generalized osteosclerosis. The range of movement sometimes might be normal, sometimes they might have affected with osteoarthritis, and again, the risk of cranial nerve palsy, although it is of less significance. So what kind of investigations you can do when you suspect an osteopetrosis? First one, and a very an easy one, is taking radiographs. So the general findings upon taking radiographs is the increased cortical thickening, the increased overall bone density, and also, as we mentioned, it will be because of the bone marrow infiltration, there will be loss of the medullary canal diameter. We mentioned that there is a bone-in-bone appearance. The loss of differentiation between the medullary and the cortical portion of the bone is a hallmark of the infantile osteopetrosis. Additional findings is Erlenmeyer flask, which is a flask-like appearance, as we see in the right upper corner, because of the flaring of the metaphysis. There is something which they describe as the regular jersey spine, because it looks like the jersey with the different hyper and hypodense area, or what they call as the sandwich vertebrae. They can have block femoral metaphysis and coxa vara. Again, these are different radiographs for osteopetrosis, and you can see how dense the bone looks. And despite that, and you might also notice fractures, at different sites. Again, here we can see and how it is sometimes very difficult to fix these fractures. And sometimes, less commonly, even the vertebrae bones might be involved, and we see fractures. Other invasive is doing a bone biopsy. We will see through the microscopic description, the primary woven bone is not remodeled. The central core of cartilage with dense and irregular bone trabeculae. Often there is abundant osteoclast with reduced marrow space. On electron microscopy, they describe that osteoclast will lack the ruffled borders, lack features of actively resorbing osteoclast. Again, this is an osteoclast abnormality. The surface of the bone has a massive, smooth cartilaginous matrix with scattered rough areas of abnormal ossification and devoid of an orderly lamellar Haversian system of normal bone, and many irregular fracture lines might be present. Now, keep in mind that when we do laboratory tests, might be difficult to find any abnormalities. In the autosomal recessive, you might find at certain cases increase in the acid phosphatase or increase in the PTH with or without hypocalcemia. But in the autosomal dominant form, they are usually normal laboratory blood tests, making it difficult to be picked up by laboratory tests, meaning you will have to depend on the radiological findings. So there is other differential diagnosis that we should keep in mind? Yes, there is a condition called as the melanohiostosis. It's an irregular growth of new bone tissues. It is a rare and it is a benign, painful disorders of the extremities characterized by the formation of periosteal new bone. Patients typically present in the first 4 decades of life, and usually they will present with localized pain and reduced range of movement. They are usually described radiologically with a dripping candle wax appearance, with dense hyperostosis that flows again the cortex of the bone. So treatment is usually observation. Surgical bone resection are sometimes indicated if they have severe symptoms and joint contractures. So when we see the osteopetrosis, how we differentiate it from this condition, osteopetrosis is more generalized, whereas the melanohiostosis is more localized, might be seen unilaterally, limb-specific. And here the bone density, it is again more generalized, where here it is focal hyperosteosis. And as we mentioned, the other features which we'll see on the X-ray when it comes to osteopetrosis, like the bone, the within bone, the sandwich, this is more specific for osteopetrosis. And the other ones, the systemic involvement, anemia, pancytopenia. Whereas osteopetrosis is genetic, there is no genetic usual association with melanohiostosis. And usually we will see it in the systemic more in the common, as we mentioned, in the autosomal recessive form. Other differential is osteopoikilosis. This is again a rare benign inherited genetic condition, but usually they present with numerous small dense spots, like they will have just bone islands. They are usually spots like dense areas in the bones. Osteogenesis imperfecta, keep in mind, especially when we see it very frequently in pediatric age group with frequent fragile bones, and they have fracture easily with minimal or even no apparent trauma. And mainly it is because of defect in the collagen production or structure. And again, it is an inherited disorder. Again, there is an autosomal dominant and an autosomal recessive form. But usually here, the bone is not dense. It is the other way. It is very fragile and very reduced the density. So they have frequent fractures, but other things that help us in also finding is the type of bone deformities, the blue sclera, that is some observed in cases. But again, if you see again the dental issues, the hearing loss, again, it can make it one of the differential diagnosis. So radiographs will always help us, and of course, the genetic testing will help us to differentiate between the two. So again, now coming back to the thing, which is the treatment of this condition. So we have to manage the symptoms and prevent complication, improve the bone marrow function, reduce fracture risk, address the neurological deficit, and enhance the quality of life. So this requires a multidisciplinary approach from orthopedics, hematologists, neurologists, genetics. So you can see it is multidisciplinary. Supportive care is the main primary management, and individualized treatment will be based on, of course, the severity. So when it comes to the severe infantile form, the baseline treatment or the main primary curative option is the hematopoietic stem cell transplant to replace the defective osteoclast with a more healthy donor cells, which will help us to improve the marrow function. But keep in mind, it is not as easy as it sounds, because sometimes it is very difficult to find the appropriate donor, the HLA matched, and also sometimes the post-transplant complication may include engraftment failure, or sometimes they will have the graft versus host disease. So again, here they have mentioned the conditions. When it comes to the autosomal recessive, it is always better to go into the stem cell transplant. Other type, which is still very controversial, is the use of bisphosphonates, which is a drug that inhibits the osteoclast-mediated bone resorption. Keeping in mind, it is usually used for treatment of osteoporosis and not osteopetrosis. Its role in osteopetrosis is very complex, very controversial, with very limited evidence. Why it have to be careful? Because the function of the bisphosphonates is also to reduce the osteoclast activity. So already osteopetrosis, there is reduced osteoclast activity. So it is not really much helping if we will think about the pathophysiology. However, certain forms of osteopetrosis with some residual osteoclast function or specific metabolic profiles have been considered for bisphosphonate therapy to modulate the abnormal bone remodeling. So this is what we mentioned, the osteoclast. Usually the bisphosphonates, they try to prevent the osteoclast from further resorbing the bones, which usually will help in cases of osteoporosis. But in osteopetrosis, it is already these osteoclasts are defective. So might not really help the use of the bisphosphonates. So again, it is very not routinely recommended, and it will be considered in very specific scenarios and experimental settings under expert supervision. There is other potential role of interferons, which is known to influence the bone metabolism indirectly, such as modulating the osteoclastogenesis and osteoblast activity. So current research does not really identify interferons as the central players in the treatment. Some suggest that interferons, particularly interferon type 2, can inhibit the osteoclast formation and activity, which may be relevant in conditions with excessive bone resorption. But in osteopetrosis, where the osteoclast function is already compromised, again, interferon pathways are not typically targeted. Coming to the surgical interventions, again, it is one of the mode of treatments, but they will need fracture fixation, decompression surgeries for the cranial nerve compression, and corrective osteotomies. Marrow failure and osteopetrosis, sometimes we will need to support systematic with blood platelet transfusion for anemia. We have to really be careful with pain management. As we said, they usually have chronic pain. We have to be very careful with the physical therapy for mobility and fracture prevention and regular monitoring of the neurological status. Regular radiograph assessment of the bone densities. Blood tests, as we mentioned, might not be much helpful, but some bone marrow studies may sometimes be indicated. Neurological evaluations from time to time. So my lifestyle will be talking about the future therapies. Again, so far, it is still the hematopoietic stem cell transplant remains the mainstay for severe cases. But now with the advancement of technology, gene therapy might be an emerging research area. There is preclinical studies in animal models which shows promising demonstrating restoration of the osteoclast function and improvement in the bone pathology. So let's hope that this is a really emerging field, that we hear more and more advancement in this area. And this is for references, and thank you.
Thank you so much, Dr. Maria, for the excellent review of osteopetrosis. This disease is really complicated, and it has a devastating course on the patient and his family because of the fractures and because of the hematological manifestations like recurrent infections and the bleeding. And as you said, they usually die young at the age of 10 because of infection or bleeding. So I don't see questions. We'll move to the next speaker. Our next speaker is Dr. Zainab Tourani. Dr. Zainab Tourani is an Arab board certified anatomical pathologist and senior resident in hematopathology. She successfully passed the fellowship examination of the Royal College of Pathologists in 2021. Dr. Tourani completed her internship at Salmania Medical Complex and King Hamad University Hospital in Bahrain. Welcome, Dr. Zainab.
Hello, everyone. I'm just waiting for the slides to be shared.
Okay.
Yeah. Okay. Thank you so much, first of all, to the organizing committee, and special thanks to Dr. Najat for giving me this opportunity to be presenting today. So without further ado, we'll start. Okay, so this presentation is going to be a case-based presentation. I'll be discussing a very miscellaneous different ranges of cases. I have no conflicts of interest. So starting with case one, about a 7-year-old boy with anemia who presented with anemia and jaundice. On examination, he had pallor, splenomegaly, which was 3 centimeters above the costal margin. And on the labs, it showed that the HB was 8.5, the MCV was 95, the retics and indirect bilirubin were high as well. When peripheral smear was done, it showed anisopyculocytosis. On bone marrow aspirate, it showed that there was hypercellularity, erythroid hyperplasia, and binucleated normoblasts or erythroblasts. So this is one of the findings that was seen around, which was, if you can see, that this is called the internuclear bridging, which the nucleus and nucleus starts to bridge together. So this was one of the findings that was seen. But this was the main finding that was actually seen in this patient, which was the binucleated erythro or normoblasts. So again, on the bone marrow biopsy, the same finding was seen along with a lot of erythroid predominance. So this patient was diagnosed with CDA type 2. A little bit about it. So we have 3 different types. So the one that is in our case related, it is of autosomal recessive disorder. And you would see the binuclearity that we saw earlier. The multinuclearity or the gigantoerythroblasts, you would usually see it in the type 3. And in the electron microscopy, which shows a little bit of peculiar appearance, in the type 2, you would see the cisternae that forms beneath the plasma membrane. In type 1, I have a picture for it. You would see the spongy heterochromatin appearance. And then you would be looking into the mutation of the gene. So this type 2, you would have the SEC23B, which would be mutated in it. Okay, so this is a picture just showing what are the different types of changes that you would see in each type. So usually type 1, you would see the first picture, which is the, I don't know if you can see the pointer that I'm pointing at. Can you see the pointer when I point at the picture?
Yes, Zainab, we do.
Okay. All right. So this is the internuclear bridging that is usually seen in type 1. And when you come to the binucleated erythroblasts or the normoblasts, you would see it usually in type 2. And the multinucleation or the erythroblasts, you would see it usually in type 3. This is the spongy heterochromatin that I was talking about, which is seen in type 1. And usually if there is like a space here, that is the peripheral cisternae that is seen in type 2. So I'm not going to go much into the therapeutic approach, but this is the general idea about it. You might need to transfuse the patient, and because of like the degree of transfusion that you do, you might need to monitor the iron overload. So by doing iron chelation, you can consider interferon alpha splenectomy, mainly for the CDA2, because the destruction is usually happening in the spleen itself. So you would be tackling that by tackling it with a splenectomy rather than splenectomy used in 1 and 3, which is not very effective. And stem cell transplant can be considered. So case 2 is about a 3-year-old girl with fever and abdominal pain. On examination, she had pallor and splenomegaly. Laboratory investigation showed HB of 6.5. There were raised WBC, raised retics, and raised LDH. So this was her peripheral smear. This is what it was showing. As you can see that there are many target cells and there are NRBCs, nucleated RBCs. There are boat-shaped cells. There are sickle-shaped cells. Okay, some teardrop may be present around. Okay, so this was her, the electrophoresis when it was done. And it showed that the S window, if you can see, it's 78.9. So there is some sickle HBS there. And what is of our interest here is the A. This is 3.5. So if it is around like more than 5% is something that we would consider in a B plus rather than a B0. So basically is that you are going to check, our area of interest would be the A rather than A2 here, because A2 can be seen in both the B plus, beta plus and beta 0. Okay, so I'll just clarify it here. So the sickle was 79% and the fetal was 9%, and the A0 being less than 5%, we would be thinking more towards a beta 0 than a beta plus. If we have it more than 5%, we would be thinking of it as a beta plus. So this patient was diagnosed with sickle beta 0 thalassemia. So just to show you as a summary, beta plus plus here, you have, like I said, the A2 would be high in both, so you won't be relying on that. The sickle you will see in both, but the A is something that you would, it would be of an area of interest. The beta plus, it would be more than like 5%, but in beta 0, you're not going to see the A. And the clinical severity is something also to keep in mind, because in the beta 0 or the HBS beta 0 is when you would see them presenting also more severely, just like a sickle cell disease patient, rather than the HBS beta plus, where they might present more mildly. So when you have a low MCV, you should be thinking about ruling out other causes like iron deficiency anemia. So you would rule out that. And once you have an absence of a concurrent iron deficiency and you have a low MCV and the presence of HBS, you should raise a suspicion of HBS beta thalassemia. And as we know that there are no beta globulin chain that is seen in HBSS or HBSC or HBS beta 0 disease, like in our case. And they will not have the HbA, as I mentioned. And the beta thalassemia, it is characterized by increased HbA2 production. So therefore, in any HBS beta thalassemia syndromes, you would have A2 production, increased A2 production. And also to keep in mind that hydroxyurea will also give you a high MCV. These patients, they will have lower HBS with a higher HbF. So an HBSS, because of the chronic, simple or exchange blood transfusions, you would usually see an HBS percentage unlikely to be higher than 90%. They will typically have both the HbA and HBS. And this is just a summary of what I mentioned earlier. Again, this is just a summary of what I mentioned earlier, is where you have to look into the HbA. So case 3 is about a 2-year-old girl who presented with fever and seizures. On physical examination, she seemed a bit confused. She had a neck stiffness, tonsillar exudate, and lymphadenopathy. So I don't know if I can have access to the chat, but I just wanted to ask the audience if they would know what is the abnormality here. I don't know if anyone would. Okay, maybe that's. No, okay. Okay. So Dr. Najat, can you still hear? Yes. Okay, yes. These are atypical lymphocytes, yes. So what you would see is that these lymphocytes, they are sort of like scalloping around the RBCs, and you would see that the cytoplasm, yes, you can see clumping as well. Yes. You would see this this bluish cytoplasm around. And I think I have a better picture where you would have a little bit of vascularization. Yes, is there. So these are atypical lymphocytes. So lab tests were done. The monospot test was positive. The WBCs were increased with lymphocytosis. The EBV IgM was positive, and EBV DNA copies in the CSF was positive. She was eventually diagnosed with infectious mononucleosis, which was caused by the EBV. Case 4 is about a 6-year-old girl with fatigue, jaundice, and dark urine, a recent history of viral illness. So this is an important thing to keep in mind. Physical examination showed pallor, mild jaundice, and splenomegaly. The lab test showed an HB of 6.1, and the retics were increased. Okay, so what do you think is the abnormality here? Anyone? I don't know if Dr. Najat, is there a possibility to see maybe the chat box or something? I don't know why. Okay.
You have access to see the chat box, Doctor.
I have the subtitle coming up. I don't know if I can. Okay, there. But the subtitle, how can I just remove that? Okay, thank you. Yes, so engulfed RBCs, yes, you would see these erythrophagocytoses, correct. So you see them in the neutrophils and the monocytes, yes, and you can see a little bit of a clumping happening in the background. Okay, so again, you see here clumping that is happening around the neutrophils, and the same thing here, you have the erythrophagocytosis. So investigations were done. The data showed C3D positivity, and the Donut-Landsteiner test was positive. Any ideas to what do you think this would be? Okay. So this is a case of a paroxysmal cold hemoglobinuria. It's PCH. So PCH is basically to show the polyclonal biphasic IgG. So when it kind of binds at cold temperatures, and when you warm it up at 37 degrees, you would have hemolysis happening. And mostly it is seen in children less than 5 years old, especially they would have acute hemolysis within 1 to 3 weeks after a viral or bacterial infection. It is rarely seen in adults, and it is transient and self-limiting. So, case 5 is about a 10-month-old with anemia and jaundice post-immunization. Physical examination showed pallor, jaundice, hepatosplenomegaly. On lab investigations, she had a HB of 5.3 and retics were high. What can you see here? Anyone? Yes, a lot of clumping, a lot of agglutination is seen. So when the DAT test was done here, the C3D was very much positive, and the cold agglutinin was very positive. Here, this is a case of a cold agglutinin disease, and it is an immune-mediated hemolytic anemia, which typically is characterized by complement-mediated hemolysis. Usually, their presentation would be with having acrocyanosis, Raynaud's phenomenon, or symptomatic anemia. And it is important that we would differentiate it from the non-specific cold agglutinins, where it will differ with having, like the CHAD in our case, would have a high titer antibody, which is a more than 1:500 at 4 degrees, and whereas the thermal amplitude will also be high. And also we have it being positive for C3D, which you will not see it in the non-specific agglutinins. So this is just a summary to show different types. So the warm AIHA, what it would show, which also antibodies, and in our case, which was the cold AIHA, which happens under 4 degrees. It is in cold conditions, and you will have the C3 being the positive, as in our case. And it usually happens because of causative agents like infections, mycoplasma, EBV lymphomas, and the presentation that I mentioned earlier. And the PCH, which we discussed earlier, where we have the Donut-Landsteiner test that we would do here, which is important, and the presentation where they would present post-viral infection in children usually, and the other different types. If you would like, you can, if it's going to be shared, you can go through it. So case 6 is about a child with recurrent respiratory infections. Physical examination showed pallor, developmental delay features, and hepatosplenomegaly. So what do you think is this cell? Anyone? So This is on bone marrow aspirate. Okay, so these are the foamy cells. Okay, as you can see, all of these foams that are forming, which are seen in the Neyman Pick cell. Okay. So I kind of kept two kinds of pictures for comparison purposes. In this case, it's not the same patient, but it's just to compare two different kinds of cells, which is an important case or two important cases that usually shows up in board exams. So this is the another cell in another case. What do you think this cell is? Anyone? Yes, this is a Gaucher cell. So you would have this crumpled paper appearance or crumpled tissue like a paper appearance in the cytoplasm. So this is a Gaucher cell. Okay, so just to differentiate it, you would have actually, this is just a Gaucher cell here, and this is just a Prussian blue that was done, and it is positive, and PS as well. This is the difference between a Gaucher cell and Neyman Pick cell. And of course, their presentations are different, their severities are different. I'm not going to go into that detail, and the genetic mutation is different. In Neyman Pick, you have the SMPD, and Gaucher cell, you would have the mutation in the glucocerebrosidase. So these are larger. You have the crumpled tissue paper-like appearance in the cytoplasm. And the Neyman Pick, you will have these foamy vacuolated cytoplasm. So SMPD1 is the mutation seen in the Neyman Pick. GBA is the mutation seen in the Gaucher. Okay, so these are two different diagnoses, two different patients. Okay, this is for your own reference, just to differentiate between Gaucher disease and Neyman Pick. They are both lysosomal storage disorders. They are both autosomal recessive, and they present a bit differently. In Neyman Pick, it's important to keep in mind the chair red spot in the macula that is seen, which is also seen in the Tay-Sachs. The prognosis, the type 1 in Gaucher's, it has a good prognosis with treatment, whereas Neyman Pick, the type A, it's a more aggressive mutation, so they would have a poorer prognosis. Case 7 is about a 14-year-old girl with easy bruising, menorrhagia, and hemoptysis. On physical examination, it showed pallor, petechiae, and bleeding. On laboratory test, it showed a platelet that was really reduced, and bleeding time was increased, high MPV. This is something that is important. The restositine response was absent with light transmission aggregometry. What do you see here on peripheral smear? Yes, these are certainly giant platelets. Okay, so this patient was diagnosed with Bernard-Soulier syndrome. As I mentioned, that restositine is absent. Here, this is important to keep in mind because it would be absent, unlike having, for example, the response in Glanzmann, being the other platelet disorder. I have a table that summarizes all of them. So what is Bernard-Soulier? It is a rare autosomal recessive disorder. It is inherited platelet disorder. It affects the platelet adhesion because of the defect in the GP1B9-5 complex. It is the receptor for von Willebrand factor, VWF. So this is the cause that we spoke about. The gene that is involved is the GP1BA, GP1BB, and GP9. And the pathophysiology behind it is that the platelets cannot bind to the VWF. So there's a defect in the adhesion and poor clot formation. You would have thrombocytopenia and also giant platelets, which we saw earlier. This is important, the defective restositine and response. And flow cytometry for GP1B can be done, and platelet aggregation studies. The treatment would be supportive care, antifibrinolytics, platelet transfusion if it is needed. This is just the different kinds of syndromes that are seen, like Bernard, Glanzmann, Wiskott-Aldrich. You have the ITP, DTP, gray platelet syndrome, May-Heglen, all of them with their defects and inheritance and clinical features, which you can, I kept it as a reference in case someone is interested. So I have two more cases that I kept just for fun, which comes in between a histopathology, which is my specialty, and hematopathology. Okay, so this is a case of a 10-year-old girl which she presented with an enlarged tender axillary lymph node. An excisional biopsy was performed. She had a new pit at home. Okay, so this is something to keep in mind. I don't know if someone can maybe uh, say what are these? If someone knows a bit of histology here. Okay, so when this was done, the biopsy, this was seen. Okay, I'll just go higher power on them. So a lot of these are seen. These are stellate abscesses. And if you can see it around, these are the histiocytes around. Okay. And in between, you might see the inflammatory cells. So this is a better picture. Okay, so there is necrosis. Okay. And there are these histiocytes around. Okay. And this is a cat scratch disease. Okay, so it is self-limiting. It is caused by Bartonella henselae. And as we saw earlier, there are the stellate abscesses, and these are the, sorry, these are the palisading histiocytes around. Okay. And the necrosis, and you can see inflammatory cells, neutrophils, and it depends on which stage you're in. So you would see different kinds of inflammatory cells. So it is caused by Bartonella henselae. And usually if you want to do staining for it, you would do a silver stain, which is like Warthin-Story is a kind of silver stain. So you would do that, and confirmation is by serology or PCR. And this one I already just mentioned it. It's just another kind of summary on that. Now, case 9 is a case that presented to Salmonia. So this is a case of a 13-year-old girl who presented with a 1-year history of left upper arm pain, numbness, redness, and swelling. The symptoms started after receiving the COVID-19 vaccine, which was administered at the same site in her arm. So on examination, the swelling was tender, erythematous, firm, non-mobile, measuring around 6 by 6 centimeters. So this case is the primary pathologist was Dr. Zainab Harb, and the radiologist was Dr. Rula, and the surgeon was Dr. Abdurrallah. So this was, so in courtesy of them, I'm presenting this case. So an excisional, after she had a long story. She had a lot of biopsies done. She had a lot of back and forth, not very confirmatory diagnosis. And then when an excisional biopsy was done, which is this, you can see this lobulated appearance of this tumor. When you go higher power, you see these cells. Okay, these are just lymphoid aggregates on the side. Now, these cells have not much of a clear cytoplasmic border. They have a very plump and a lot of cytoplasm, very abundant cytoplasm, and apparent nucleoli is there. Okay. Can someone tell me what kind of cells are these? Very plump, very abundant cytoplasm, very lightly eosinophilic. Anyone? So there are a few other features in this slide, but I'll show you a better picture. So this is just showing this lymphocytic infiltration in between the bluish, the darker bluish in color. Now, this is the cell of interest that was seen in this patient. What do you think is the cell? Whoever says it will get a virtual hug. Anyone? Anyone who wants to give another go? Look at this cell. What do you see that is different about it? Okay, okay, so what do we call it when that happens in in histopathology? No, these are not spindle cells. There is phagocytosis happening. So what is the cell called? What is it called? So there is embryopoiesis that is happening here. So you can see this is the cell itself, and there are other cells inside its cytoplasm. Okay, so CD68 was very much positive in those cells. As you can see, the bigger ones, they are picking it up. S100 is beautifully picking up those bigger cells, as you can see. And you can see that it's inside the cytoplasm is the embryopoietic cells. OCT2 was nuclear positivity, it showed. This is a case of a Rosay-Dorfman disease. And what is very peculiar about this is that it developed just in the site of the administration of the COVID-19 vaccine, which is a very rare thing. Maybe around 2 to 3 cases that are reported worldwide. So Rosay-Dorfman disease is a benign sinus histiocytosis with massive lymphadenopathy. It will show histocytic proliferation, which we saw earlier. It will show these embryopoietic cell. The mutation related to it is the BRAF. It has a good prognosis, and it is usually positive for S100, CD68, CD163. We have to differentiate it from Langerhans cell histiocytosis, where in the Langerhans cell histiocytosis, you will have positivity for CD1A and Langerhans, and it will be negative here. And they would come with bilateral lymphadenopathy usually and resolve spontaneously. This slide is in courtesy of my friend who's a consultant in the UK. You can scan this. This is just showing you the different scenarios in hematology, and for your board exam purposes, for your daily practice, it would really help you. Thank you.
Thank you, Dr. Zainab, for the excellent presentation. And as I don't see questions, we'll move to the next speaker. Our next speaker is Dr. Christina Krispok. Dr. Christina Krispok is a senior consultant medical genetist with expertise in genetics and genomic disorders. She holds a PhD in medical genetics and European Board certification in medical genetics and genomics, with advanced international training in cytogenetics, genetic counseling, nutrigenomics, and the pharmacogenetics. She is a member of several international genetics societies and an expert with the WHO Global Network for Rare Disease Disorders. Dr. Christina advocates for ethical practice and public education, emphasizing the personalized genomic medicine to enhance health and disease prevention. Please, Dr. Christina.
Good morning, Dr. Najat and the entire colleagues and audience. Thank you very much for inviting me to contribute to this excellent event. After the previous very nice presentation, we'll switch a bit to the genetics part of hemoglobinopathies, discussing from testing to diagnosis and prevention. But my slides are moving. So we know that hemoglobinopathies are a group of inherited anemias characterized by decrease or absence in the production of globin chains alpha and beta, leading to an imbalance in the hemoglobin molecule. And we also know that hemoglobinopathies are the most frequent genetic disorders on Earth, and they monogenic one, and with an increased global burden, and majority of them are having recessive inheritance, and carriers are generally silent. So everything starts with this magic molecule of hemoglobin, who is an helical-shaped polypeptide made by 2 chains of alpha and 2 chains of beta, together with a heme group. But the magic of this molecule starts with the genes. So we have two clusters of genes on the chromosome 16, the alpha genes, and the chromosome 11, the beta genes. And we know that there are two shifts in embryonic time. We have the zeta and the embryonic chains who are working around the 8 weeks of gestation, and then slowly the gamma genes are starting to express more to create the fetal hemoglobin. And then prior to birth, the gamma synthesis is slightly decreasing to let the beta and the delta to express. And then at birth, we will have the hemoglobin A1 and A2. So if these genes are in the right place, in alpha thalassemia, we have 4 genes, 2 from each parent. If they are there, then we have a normal phenotype with a normal hemoglobin and no anemia. But if these genes are missing, this is depicted with alpha minus, then we have a silent carrier, again, normal hemoglobin A and non-anemia. But then if 2 of the genes are missing in cis or in trans, then we have again a hemoglobin A, but a mild anemia. Then if 3 genes of alpha are missing, then we have hemoglobin H with an intermediate anemia. And we all know that if all alpha genes are missing, we will have the hydrops fetalis, who is not compatible with life. And in beta thalassemia, we have 2 genes, 1 from each parent. If they are present, we have a normal hemoglobin A with non-anemia. And then we have thalassemia minor if only 1 gene is affected, and thalassemia major on both of them are affected with the severe anemia. And in case that the gamma chains are still working and all the rest known, then we'll have only hemoglobin F and with a mild anemia with the persistence of the fetal hemoglobin. In beta thalassemia gene, according to the changes that are happening inside of the gene, we have qualitative variants and quantitative variants. So the qualitative variants, we know hemoglobin S, who is leading to sickle cell disease, the famous C20A to T with glutamine to valine in the position 6, hemoglobin C, glutamine to lysine, hemoglobin D, Los Angeles or Punjab, and hemoglobin O Arab when we have glutamine in position 121 to lysine. And quantitative variants in the beta gene, beta plus or beta 0, different changes inside of the gene are leading to various types of beta thalassemias. It's a bit more complicated in practice, and we find this in counseling with alpha thalassemia, and people are not always very clearly on how these genes are coming together. So they are in cluster 2 from each parent, as I said before. And then if we know this very clearly, it will be easy then to assess when we do the test if it's 2 alpha genes missing or only 1 alpha gene missing. The difference is quite big in between asymptomatic and minor alpha thalassemia. But I want just to pay attention to that these genes can be in cis or in trans coming like that, leading to mild microcytic anemia. Now, we know that all of these hemoglobinopathies are having a recessive inheritance, so it's so important to identify if parents are carriers and how are them in alpha thalassemia and also in beta thalassemia, and then to assess the risk for the offsprings, that it's always 25%. With the variants in alpha thalassemia that I already mentioned it with the silent carrier or minor, and in beta thalassemia with minor or major thalassemia. And in sickle cell, again, if 1 parent is carrier, all children are having a risk of 50% to be carriers. If 1 parent is affected, all children will be carriers. And if both people or partners are carriers, then the risk to have an affected child is 50%. And also we have a lot of cases where 1 parent is affected and the other one is a carrier. So then the risk is moving from 25% to 50%. And again, that's very important to express in practice because sometimes general public doesn't understand how genes are moving. So looking to molecular pathology and clinical phenotype, as I already described, alpha thalassemia. In beta thalassemia, We have minor and major. The minor one is just reducing of the expression of one beta globin gene with changes inside that we'll speak soon. And typically it's asymptomatic with normal hematocrit, low mean corpuscle volume. And the major thalassemia, it's reduced expression of both beta globin genes. And then what is happening on the molecular is that the unpaired alpha chains are accumulating and leading to oxidation damage to the RBCs and erythroid precursors, leading to profound anemia who requires transfusion, depending by transfusion, and again, a lot of complication linked with iron overload. Hemoglobin S, we all know the sickle cell disease, what it's happening inside with frequent crisis, transfusion, and acute chest syndrome when inherited as hemoglobin SS. And we also know that there is also combination in between hemoglobin S and beta, also a severe form of sickle cell disease. And we have hemoglobin C with mild hemolysis and anemia where it is inherited in homozygous, and asymptomatic where it is heterozygous. Hemoglobin E, it's also frequent in Southeastern Asia and other parts of the world with mild anemia. And hemoglobin F, we know that this is more than 50% of the hemoglobin of birth, and it's largely absent by the age of 6 months, and has a greater oxygen affinity for the RBCs. And it's very important now in the era of genomics to pay attention to the hemoglobin F, and we'll discuss soon, because that's the way in which we are trying to treat these disorders, increasing the amount of hemoglobin F. So how we do the testing, how we reach to identify all these changes and to clarify if a person is homozygous, heterozygous, and what kind of change are inside. Of course, starting first with the clinical suspecting anemia patients, or in prenatal diagnosis, or in a health checkup. There are biochemical tests, everybody is aware about CBC and HPLC, and according to the values of MCV and MCH and the level of hemoglobin A2, we can assess through the carrier, through the screening testing, if it's a beta thalassemia carrier or alpha or beta thalassemia carrier, and or is just an abnormal hemoglobin. And therefore, we need to certify this observation by molecular analysis. Now, there are different ways of identifying them. There are tests that are focusing for common and known mutation, like IRMS PCR or RE-PCR or GAP PCR. We also can do microarray or MLPA or even sequencing of the gene. But if we do not know the mutation and we are moving more than the most common one frequent in the population that we are referring, we need to consider then gene expression, heteroduplix analysis, and others. Now, in the era of genomics, we move from the conventional methods who have, how to say, they have low cost, low short time around, and unfortunately, their accuracy rate is relatively low because, again, as I said, it's focusing on the mutations that are more frequent and known to be prevalent in a population. Now, in the genomic era, we move to the NGS, next generation sequencing, that is able to identify with a higher accuracy a lot of changes. Not so much known, it's the third generation method, who is having a much higher accuracy comparing with traditional methods, and has shown significant advantages in thalassemia detection because can cover hundreds of alpha and beta deletion variants in a single test, surpassing the coverage of all previous methods for thalassemia detection. And we know that from the research done so far that TGS improves the detection rate of positive thalassemia genes up to almost 20%. Avoiding undiagnosed cases that are missed by traditional methods. The most known third-generation platform is PacBio, and for example, this slide, it's depicting from different sites of the world, different research groups who use it, what is their achievement. So in different publications, from 100 detection rates with higher genotype accuracy of individuals who are carriers, more than 10 rare ground poor mutation, higher detection rate, and more detection of rare genotypes. So we are going to be from somewhere from 90 to 100% capacity of identifying all changes. And that's very important because, as we know, if we focus only on the most known one, we will miss it. And that's happening if we do carrier screening of the large population on methods who are on a low cost, but covering only a limited number of changes. So I just prepared some, just to review which are these changes. In alpha thalassemia, we have hundreds of changes. Some of them are more frequent in different populations and are listed like that. In Mediterranean, in North European, in Asian, in South America, and also in Middle East. Depends where they are localized, in exon 1, 2, 3, or in the termination codon. And it's very important to know where the change it is and what the change is it inside, not only where it's distributed, because it's linked with different kind of phenotypes. So it's a bit different in between alpha plus or alpha 0. So then in homozygous status, this will be leading with a manifestation, not a silent one. And we know that some of them are very frequent in Mediterranean and Middle East population. This is very helpful in genetic counseling and also for not only for the clinical assessment of these patients, but also for the next generation and helping them on pre-implantation genetic diagnosis to assess correctly how severe form can be. And many other mutations in different parts of the world. Now, in beta thalassemia, again, we have scattered hundreds mutation all over the world. Some of them are frequent in Mediterranean, in Middle East, or in African American descendants, or in Indian subcontinent, or in Chinese, or in Thai. And again, it's important not only because nowadays people are migrating, but we know from practice that some of these changes are associated with different type of clinical phenotype. So, for example, quite frequent in this part, IVS1, 2, with the origin on Tunisia, it's linked with beta thalassemia major. So why it's important? Because in practice, if you find a report done by any kind of lab with a variant, it's very important to look from where this change is coming, where it's frequent, and what kind of phenotype it's associated with. And again, this has big implication for the genetic counseling. Different kind of places in the gene are linked with different phenotypes. The most frequent for the hemoglobin beta gene changes are the frame shift and the splice site changes, and then missense, promoter, some of them point mutation, frame shift, or nonsense. And we know again that in beta thalassemia, depends where this is, you may have a beta plus or beta plus plus or beta 0, beta plus a genotype linking with a different phenotype. And of course, if deletions are in the genes, they may be more severe. And many groups all over the world are still reporting new variants in beta globin genes. And that's a publication from 2020 who presented new changes found in their population. So like that, as many people are sequenced all over the world, then a new mutation can be there. So therefore, it's so important to go extensively when you look for diagnosis. If you just stay on the most frequent mutation that you know that are running in your population, you may miss people who are actually carriers and they do not know. And this has as a consequence a child affected in the next generation. Again, another publication from Pakistan with new mutation identified there. And not only that we know which are those who are pathogenic, but unfortunately there are many changes who are at uncertain significance. And that's so important that groups from different populations are presenting their data and are sharing that to assess if this uncertain significance variants may have any implication for the phenotype. Now, hemoglobin SC is the second most common hemoglobin variant after hemoglobin S in US, and the third most common worldwide after hemoglobin S and hemoglobin E, and it's caused by a single gene mutation at codon 6, leading to a substitution of lysine to glutamic acid, different than the classical hemoglobin S. Now, if we just remind ourselves how are then the changes that are leading to alpha thalassemia and beta thalassemia, what is very important is that all these variants in the genes can have modifiers. So we know that there are ameliorating genetic modifiers, so that, for example, if a person is having a change in beta hemoglobin gene, but in the same time is co-inherit alpha thalassemia, this will ameliorate the beta thalassemia phenotype. And if we have increased synthesis of gamma globin genes, then again, the phenotype will be mildly. If we have dominantly inherited beta thalassemia mutation or coexistence of excessive alpha globin genes, then this will be with worsening genetic phenotype. And this is also very important because we observe this in practice, that people who are having the same changes in the genes are having a different phenotype. And again, that's very, very important for the counseling on the next generation. Just to present how complex the genetic modifiers are, I just want to pay attention to some of the genes on the left side of the slide. Everybody probably know about B-cell lymphoma leukemia 11A gene, who is localized on the chromosome 2, the short arm of the chromosome 2, and who is a zinc finger protein. And this is a DNA binding protein and a major transcriptor repressor of the gamma globin expression during adult erythropoiesis. And it's found within multi-protein transcription complexes and does not act alone. You can see what is around. Yeah, it's having cooperation with other transcription repressors like GATA1 and TAL1 and FOLC+1. So all these molecules form a network altogether who are inhibiting the gamma globin expression and hemoglobin F in adults. But however, in the fetus, the BCL11A expression is suppressed in order to maintain elevated amounts of hemoglobin F. And in this regard, the inhibitor H2 connects with the BCL11A enhancer to decrease the chromatin availability and binding of the transcription factor GATA1. So why it's important? Because now gene editing, it's aimed to address BCL11A to improve gamma globin expression. And we all know that this is an amazing achievement of science and research, and is translated nowadays in practice in Casgevy therapy. So the gene therapy, it's doing that. The Casgevy, it's having that working on the BCL11A to increase the hemoglobin F and decrease the sickling. So you can see how complex are the genetic modifiers, and it's important in practice to understand that it's not only the change in the gene, but how the gene are functioning in a big network and what other connection are helping in expression or repressing the gene expression. And this is even much more complex to see that everything that is in red is decreasing the expression of the hemoglobin genes, and everything that is in green, it's stimulating the expression, of course, in a very, very complex network. More than that, there is a lot of epigenetic influence in thalassemias and in sickle cell. To remind, there are different elements who are surrounding the DNA, the histones proteins, who can switch on or turn off switch off or turn on the expression of the genes by methylation, acetylation, and microRNA. So in the cartoon on the left side, we can see what is happening in the fetal stage with the hemoglobin genes that are controlling the fetal hemoglobin. They are in green, so that means they are expressing correctly. And then in adults, they will be shut off, and opposite what was active in the fetal, it's then turned off in the adults. And what was turned off, it's turned on later on. So there is an amazing game in between acetylation and methylation and histones regulation, who are able to let the genes to express or not, so much beyond the mutation. And that's very important because now in the genomic era, we are trying to see how we can modify the epigenetic markers of the DNA without obviously touching the DNA. And what research is doing now, very advanced, hopefully in the years to come, this will translate into new therapies, is to come with epigenome editors, different kind of them in an enzymatic way, who are able either to remove DNA methylation, to remove histone methylation, or to remove histone acetylation. So without touching the DNA, just what the proteins who are protecting the DNA. So that's promising research. And hopefully in the years to come, we'll have new therapies. Now, all of these data are helping us not only to diagnose cases, but to do screening. And there is a chart flow on how we do screening for thalassemias and sickle cell, obviously based on the CBC and HPLC. And if we suspect a trait, beta thalassemia or sickle cell, and then we move correctly further to do genetic testing and to confirm the carrier status. So the states in the Middle East are really investing a lot for the past of more than 30 years in screening of the population. And can you see this is a cartoon from the study done in Saudi Arabia for beta thalassemia, and a similar one for beta thal sickle cell and hemoglobin D in Kuwait. And then many people are tested yearly, and the incidence, it's starting slowly to decrease as a result of all the screening and education of people. But I found a very interesting publication published in 2022 by a Saudi group, premarital screening and genetic counseling program in Saudi Arabia. And I found something very interesting. So people are really enthusiastic by the doctor's skills in explaining and about this very complex genetics of hemoglobinopathies. So almost 47 people are saying, yes, the doctor really explained us very clear, and we got clear answer to all our questions. And the doctor behaved very kindly and explained us everything that was needed to advise us correctly for, the marriage and for starting a family. But interesting, the reason that the frequency of this disorders, it's still there, just slightly decreasing in the last of, let's say, 10, 15 years, there are a lot of elements who are saying, despite of the fact that the doctor explained me very clearly that this is autosomal recessive and the risk can be very high if one is affected and the other one is carrier, there are elements saying, it's because of family relation, because of family pressure, because, already the marriage is done and we cannot change anything. Because the hole is blocked, because the house is ready, because we are predestined to be together, and a lot of emotional and psychological factors who are making people to take the decision to go further, to marry and have a child, despite of the fact that they've been identified being carriers or affected, and the doctor done a very thorough and detailed genetic counseling. Now, newborn screening, it's something that really help a lot in managing better the cases. And we know that in US started in 1960s and extended by the 2006 in all states. And we know that in Middle East, all states started to invest a lot in this. And that's a nice publication from Bahrain with the result of newborn screening services between 1985 and 2010, with the incidence of newborn who really decreased significantly as a result of the screening program and education of the people. So again, there is a clear workflow how to do to screen the newborns for that. And if you, according to the hemoglobin partner, if you assess that the baby may be affected by sickle cell disease or thalassemia, then it's referred to the centers responsible by that, and there is a confirmatory molecular testing which is coming in 1 month. And if the child is carrier, then the parents are also informed, and if both parents are carriers, indeed, it's important to repeat the test around the age of 6 months to certify for sure that the baby is not affected. Now, the methods that I use for the newborn screening are the classical one used for testing in hemoglobinopathies, allele-specific, GAP, VCR, Zenger sequencing. I'm highly advocating for the DNA sequencing or the new NGS platforms, or later on the third generation platforms. As I said, there are a lot of changes that are not reported as new and can be missed if we focus only on the package of the variants most known. I want to present something that it's still at the research stages, but hopefully in the years to come will be coming into clinical practice, a non-invasive prenatal testing of beta hemoglobinopathies using next generation sequencing. And there is a method called in silico sequence size selection and haplotyping, and the slide is presenting that actually this method seems to be quite accurate to predict the genotype of the fetus. So non-invasive prenatal testing means around of the age of 10 weeks of gestation, you take 10 ml blood, peripheral blood of the mom, you isolate the cell-free DNA, and then you test that cell-free DNA. The method is pretty much standardized for the past of 20 years for chromosomal disorders, and it's used for aneuploidies and structural chromosomal disorders, but now we are moving slowly on being able to perfectionate the technology to be used on monogenic disorders, especially the recessive ones. So this research presented that the method is starting to be quite perfectionate. And if you see, for example, from this cartoon, what is highlighted in bold are the one who didn't match, but many other match. And in the publication, there are almost 70 tests done, and the match is almost above 90%. So we shall expect that in the years to come, we will be able to do a non-invasive prenatal testing for hemoglobinopathies in practice. So with this, I thank you, and I'm open for questions.
Thank you so much, Dr. Christina. It was an excellent review of the coverage for the genetic background or of the hemoglobinopathy. I don't see any questions, so thanks so much. We move to the next speaker. Our next speaker is Dr. Iman Jassim Mansour. Dr. Iman Jassim is a board-certified hematopathologist with extensive international training and clinical experience. She earned her MD and BSc in basic medical science from Arabian Gulf University and completed a hematology fellowship at King Saud University in 2009. Dr. Mansour has trained at prestigious institutions, including the Westmead Hospital, Sydney, Australia, King Faisal Hospital and Research Center, and King Khalid University Hospital, Riyadh, Saudi Arabia. Since 2009, she has been a consultant hematopathologist at Salmania Medical Complex, Bahrain. Please, Dr. Iman.
Thank you, Dr. Najat. Thank you, the organization committee and the scientific committee for choosing this subject, the exploring the challenges of congenital platelet disorders. I'll go through the slides now. It won't be long. Because I'll just mention the challenges of diagnosis of the congenital platelet disorders or dysfunctional or platelet disorder. And according to the ICTH, how to diagnose or how to approach these disorders by 4 steps, ICTH committee, International Society of Hemostasis and Thrombosis, they explore very nicely how to diagnose these disorders, starting with the CBC, peripheral blood smear, and then basic investigations in the lab, and then going to the more details, and then lastly by the genetics. And just to keep in mind that the platelet is part of the huge hemostasis process in the blood, so it needs the proteins, factors, and others. So let's start with the step 1 according to the ICTH recommendation, the last guidance, which is published on 23, about how to diagnose these platelet dysfunctional disorders or inherited platelet functional defects. Starting with the medical history, medical history is the gold standard in everything, including the bleeding episodes, timing, spontaneous of occurrence or spontaneous occurrence of the bleeding, severity, local, where is it, local or systematic bleeding. Also, keep in mind to ask the patient about the transfusion blood products, coagulation products, surgical, and even the low risk of bleeding. This is very important to keep it on the step 1. Also, family history is a very important, although negative family history will not rule out the inherited platelet dysfunction. Medication, as we know, that the platelet is part of the huge hemostasis process in the blood. So even the external, like antiplatelet drug, pain medication, psychoactive drugs, even dietary food, vitamin K deficiency, all will affect this, function of the platelet. Current symptoms like, now we'll go in the step 1 is a medical history and physical examination. Okay. As you know, we examine the patient with the history of hematuria, menorrhagia, epistaxis, petechiae, hematoma, and we are using, they are recommended, the International Society of Thrombosis and Hemostasis recommend to use the bleeding assessment tool. As if it is above 2 or equal to 2, it is significant in children, above 4 and equal in men, and above 6 in women. Step 2, how to approach platelet dysfunctional disorders. Going to the very basic, complete blood count, CBC. In the CBC, we measure the platelet count. Some disorders with thrombocytopenia, some disorders with normal platelet count. The second thing in the CBC, which is very basic, the mean platelet volume, including the size distribution, large platelets, small platelets, okay? And immature platelet fraction. Most of the automated analyzer nowadays, they provide this information about the presence of immature platelet fraction. Second, the gold standard is the stained blood smear. We are going to study the blood smear, the morphology of the platelet. And I have some photo of the peripheral smear showing large or giant platelets in the peripheral smear. As Dr. Zainab Tourani present some cases with nice peripheral smear, giant platelet, thrombocytopenia. With the peripheral smear, we also measure the true thrombocytopenia. This is the morphology. Sometimes we can see that hypogranular platelets in the peripheral smear. It will give us idea to go to the next step. The other thing we can do as a basic on the step 2 of laboratory diagnosis, which is available in most hospitals, INR PT-PTT, fibrinogen, von Willebrand parameter, which is very important because the function of a platelet has a receptor for von Willebrand factor. So we have to rule out von Willebrand factor deficiency or abnormality before we are going to study the platelet dysfunctional disorders. Factor 13 as well should be ruled out. And this is also peripheral smear with the normal electron and with normal light electron microscopy and electron microscopy. Still in the second two, as recommended by ICTH group or society, that light transmission aggregometer should be included in the basic laboratory testing on the step 2, okay? On the step 3, we can repeat it or more extending the light transmission aggregometer. And I'll go through the light transmission aggregometry in details a little bit because it's very important tool described by Dr. Bourne in 1960 with five agonists to do the to induce platelet aggregation. It has a limitation. Yes, it has a limitation. What is the limitation for light transmission aggregometry? If the patient present with moderate or severe thrombocytopenia with hemolytic lipidemic sample, it is very sensitive to intra-analytical changes. So the light transmission aggregometry is a method based on transmitting along the platelet aggregation in plasma-rich platelets. Okay, we are using 5 agonists, and these 5 agonists, even in our center, we are using the 5 agonists according to the ICTH last ICTH meeting: ADP, collagen, epinephrine, restocetine, and arachidonic acid. The trap, we are not using a trap, but some centers they are using a trap. Still, we are going to study the disadvantage or challenges in studying the light transmission in the aggregometry. It is manually performed, time-consuming, require large quantity of blood volume, especially in pediatric. It is a very challenge to collect this sample. It is the sample because the platelet is very liable and short life. So it is affected by very several pre-analytical and analytical variables. We cannot transfer or ship the sample from somewhere to the other way. And as I mentioned before, it is affected by the platelet count. The lowest is 90 to 100. We cannot measure or study the platelet function with the thrombocytopenia sample or patient. This is the idea of how to the light transmit through the sample after inducing platelet aggregation. And this is the agonist, which is recommended by the ICTH: ADP, collagen, epinephrine, thromboxane, arachidonic acid, and restocetine. And each of these agonists will show us the defect in the receptors or in the granules of the platelet and show us where is the defect, and we can diagnose or giving the hints. Keep in mind that platelet dysfunction has different phenotype than the genotype. Clinically, sometimes the patient presents clinically different, genotype different, and in the lab, there are some differences also. This is the differential aggregation response in patient with a thrombocytopenia, or not a thrombocytopenia, thrombocytopathies, or platelet dysfunctional disorder. Like in Glanzmann, the reaction or the aggregation or the wave, it will be absent in most of the agonist, except in ristocytine. The opposite with Bernard-Sorgel syndrome, that ristocytine is absent and present on the others. Some are reduced, some are present. As I mentioned, that some of these agonists will study the function of the storage or the granules, delta, alpha, or delta and alpha granules in the platelet. This is showing that the first one on the left is showing normal reaction with all agonists. The other one on the right, the top one, showing absent of reaction to all agonists. The down showing us, down left, showing us Glasman, because it's absent in all and present with ristocytine. This is how we study. Now, still we are, keep in mind, still we are in step 2. Also, they put flow cytometry on the step 2, as it is diagnosis for the platelet dysfunction or platelet membrane surfaces receptors. We are studying normally CD41, CD61, fibrinogen receptor, integrin, alpha 2 beta 3, glycoprotein 2, and 3A, CD42, and other. Can the flow cytometry replace the light transmission aggregometry? This is a conflict, but in some patient, pediatric patient, infant patient, which we cannot collect 5 tubes of blood to react the platelet with the 5 agonists, we can use it as supplement. And in case of severe to moderate thrombocytopenia, we can use the flow cytometry, the basic one, the CD41, CD62, CD61, CD42A, which is studying the membranous receptor. And this is the flow cytometry for a normal patient and for Glasman patient, showing that CD61 and CD41 reduced. Now, the step 3 in guidance for ICTH is to extend or repeat the light transmission aggregometry using other measurement for ATP like HPLC or LUMI aggregometry. Both, I'll go through the LUMI aggregometry as it is advanced, but it won't replace the light transmission aggregometry. Still, we are using the light transmission aggregometry, which is described on 1960 by Dr. Bourne. Flow cytometry, because we put it on step 2, flow cytometry should be repeated or extended, add more markers. Immunofluorescence microscope, thrombin generation capacity in platelet-rich plasma versus platelet-poor plasma. But this is step 3. Is not important to go through all these tests, because light transmission aggregometry is enough and the flow cytometry. So it is either repeated or extended. So now we cover the step 3. As I mentioned before, that I'll go through a little bit about the LUMI aggregometry, which measure platelet aggregation in a platelet-rich plasma or saturated whole blood, which is advantage because we can use the whole blood in the saturated sample. It is a unique feature. It is stimulate the measurement of ATP released from D granules via different methods. But this ATP, which is released, can be measured as well by HPLC instead of LUMI aggregometry. And the induction or induced release of ATP by different agonists. The agonist is similar to the light transmission aggregometry: thrombin, TRAP6, collagen, arachidonic acid, ADP, and epinephrine. Furthermore, the whole content of ATP in dense bodies of a platelet can be measured after incubation with calcium 2P ionophore A23187. This is the graph giving us the Lumi aggregometry that in some cases ATP released, ATP reduced after induced aggregation of a platelet by the 5 agonists. This is very interesting. This is available in our center, the platelet function analyzer, which use the whole blood in the evidence of aggregometry. We are using for this 2 agonists, collagen ADP and collagen epinephrine. But this method lacks the sensitivity and specificity, cannot be used as a screening tool for platelet function, but can be used for other. It is very important, or it's useful in case of, for example, patient in surgery and he has bleeding, to detect the antiplatelet effect drug, von Willebrand. Sometimes it can be detected by this analyzer because it's using whole blood. It's fast. It's not time consuming. It's fast. It's totally automated using ADP, epinephrine, and ADP and epinephrine. Other aggregometry, which is not available in every centers, it is available only in the advanced or university centers. It's called multi-plate, measure platelet aggregation via changes in electrical impedance in a whole blood sample. Activate blood. Again, we activate platelets. Platelets should be activated either by agonist or by electrolyte. Measuring the, which leads to increased electrical resistance. The change in electrical resistance is recorded continuously, but it's not used every day. It's the same. It's a different way of measuring response of platelets to different agonists, to the 5 agonists. It has also 5 channel systems with double measurement for each test to check the intra-test variability. Now, what is the challenges in these aggregometry? It is manual, time-consuming, required, huge. It's a high quantity of blood because we need 5 tubes of blood, and it's affected by time and shipment. We cannot ship it because of liability of platelet. Now, going to the step 4 of the ICTH recommendation guidance to diagnose platelet functional disorders is the genetics. Next generation sequencing targeted for a gene panel or whole genomes, exome sequencing. Experimental. Also, they mention in the step 4 the experimental method. Some of the methods to measure the platelet function in step 3 is not available in all centers. What about step 4? Yes, it's not available. The electron microscopy, high resolution microscopy technique, immunoplot, HPLC, ELISA for soluble proteins and mediator released from activated platelets like soluble CD62, soluble glycoprotein 2B, 3A, glycoprotein 6, thromboxane, B2, and serotonin. And I'll go through the genetics, how to approach the genetics or platelet dysfunctional disorder, inherited platelet functional disorder, according to the ICTH, which is established and reviewed each year. And this is according to the 22, which is published. Okay, they divided these, the genes into 3 groups or tiers. The first group are highly associated with underlying IPDF, inherited platelet functional disorders, and are recommended to be initial to focus of genetic testing. So the group 1 are highly associated with underlying inherited platelet functional disorders. Group 2 or tiers 2 include genes that are deemed relevant for inherited platelet functional disorders, but still required to be confirmed. Step 3 or group 3 consists of genes with limited or emerging evidence. And as I mentioned, that these groups yearly reassessed at ICTH meeting. They divided this group, the genetic, according to the genetic basis. Platelet functional disorders can be classified according to the 3 categories. Number 1, affect only platelet count, platelet size, platelet shape, ultrastructure, and dysfunction according to the structure or ultrastructure, granules, membrane, effect of the receptors. Number 2 are disorders that associated with syndromic or non-syndromic phenotype. Number 3, disorders with increased risk of hematological malignancies. These are a group divided according to the genetic basis of congenital platelet disorder, which is approved by the ICTH meeting. Number 2, they divided these groups according to the functional. These genes can be classified according to the specific pathway disturbed in the platelet formation. Thrombopoietin receptor, signaling pathway, a transcriptional regulation, a granule formation, trafficking secretion, cytoskeletal regulation, transmembrane protein signaling pathway. And this table is part of a huge table showing the difference between the phenotype and genotype of the disorders. The most common one is Glanzmann thrombocytopenia, which has normal platelet count, normal platelet size and morphology, but absent of aggregation with all agonists except resistocytine. Associated clinical phenotype, none. Genes affected, ITAG2B, ITGP3. Inheritance, autosomal recessive. And this is showing us the platelet function pathway and biology related to each stage of megakaryobasis and genes found to be associated with inherited disorders. As I mentioned, it's either in the functional or the surface or the biological. Disorders that may mainly affect intracellular component. Alpha granules, gray platelet syndrome, metabolism, glycogen synthetase, production of ATP, affect the production of ATP, enzymes, glycogenase, thromboxane A2, and for example, cytoskeletal like MEH9 disorders, and giant platelet syndrome with and Wiskott-Aldrich syndrome. Disorders that mainly affect the surface component of a platelet, like a Glanzmann, Werner-Soldier syndrome, and platelet type von Willebrand disorders. Is there a benefit of genetic testing? Yes, it is very important, but we cannot jump to the step 4, jumping to the genetics without doing the basic, the step 1, step 2, and step 3 of the basic physical examination, history, basic testing in the lab, flow cytometry, light transmission aggregometry with the 5 agonists according to the ICTH recommendation. What is the benefit of genetic testing? It's enable more precise classification of inherited platelet functional disorders, confirming clinical laboratory phenotype, allowing better prediction of a clinical risk of bleeding and syndromic contribution. more accurate diagnosis, more subclassification, as I mentioned, because they put two different subclassification of inherited platelet dysfunctional disorders. It's either the platelets or the functional platelets. It can be diagnosed rare inherited platelet functional disorders when results of phenotypic laboratory tests are inconclusive. Sometimes we don't reach any diagnosis with a lab, so we can go to the genetics. Can be used to detect carrier status of family members and allow early detection and treatment of other affected family members. It provides us invaluable insight into disease and platelet functional mechanism. Now I'll just go through the case study to review the 4 steps of modulate given by the ICTH, how to approach thrombocytopenia or platelet functional disorders. 19 years old patient, male patient, presented to the general practitioner following unusual post-operative bleeding after a hernia surgery. Step 1, as I mentioned, to assess the bleeding tendency in a standardized manner and determine the need for referral to a specialized center. ICTH bleeding score used was administered, revealing a significant pathological score of 10 points. So we have to refer this patient to the hospital or another specialized lab. The patient was then referred to the nearby lab center where platelet count and morphology, plasma coagulation, and von Willebrand factor parameters were found to be normal. So step 2, doing CBC, doing basic coagulation tests available in the lab, and von Willebrand factor should be ruled out because it's part of the conflict between the platelet functional disorders or deficiency of von Willebrand factor. And then platelet function test, LTA, light transmission aggregometry, according to the Bourne, showed abnormal results with all agonists except restocity. So by this information, piece of information, it may be Glasman disorders because it's this is normal, this is normal, this is normal with all agonists, this is normal control, and this is our patient, which showed that absence of waves or reaction with all agonists except with restocity. Number 3, we go to the step 3 of the module of ICTH, how to approach platelet functional disorders. For specialized platelet diagnostic, the patient was further referred to a university hospital. Consistent findings in aggregometry were observed. So, as we mentioned before, that the aggregometry is either to be repeated with extended panel or to be reviewed, along with complete absence of glycoprotein 2B, 3A receptor assessed by flow cytometry. Flow cytometry done, and light transmission aggregometry reviewed. Analysis of platelet granules by LUMI aggregometry and flow cytometry shows no abnormalities. And inherited platelet functional disorders of autosomal recessive Glasman was diagnosed. Now, step 3 is doing the genetic testing. Genetic confirmed this diagnosis by identifying homozygous pathogenic stop mutation in ITGP3, encoding the beta 3 subunit of the receptor. In conclusion, how to approach a patient with platelet dysfunctional disorders. As I mentioned before, platelet is part of the huge hemostasis process in the blood. We have to rule out other disorders like hemophilia, von Willebrand factors disorders or deficiency, and then start doing workup of the suspected inherited platelet functional disorders. It is a challenge, very challenging. Why? Because all pre-analytical consideration taken in mind, the ability of the platelet, short life, these platelets are affecting by movement. The blood should be withdrawn and tested immediately. It is affected by medication intake, diet intake. There are so many differences in the lab, and it is not a standardization, not yet standardization, because it is not a standardization, especially for the platelet functional, which is affected by multi-parameters, pre-analytical, analytical. The post-analytical, it can be introduced with the AI nowadays, the fashion of AI. But the problem is that the short life of the platelets, it's affected by movement, cannot be transferred from one lab to the other lab. As I mentioned, the plasmatic bleeding disorder, von Willebrand, hemophilia should be ruled out. Then we should study the platelet disorders. Well-established method for platelet examination should be used. We should follow the recommendation of ICTH or the modules of bleeding score. The basic should include CBC, platelet morphology, and light transmission aggregometer should be induced or included in our testing for the platelet function, as recommended by the ICTH, flow cytometry as well. Genetic analysis are very important. Thank you very much.
Thank you so much, Dr. Iman, for the excellent presentation. And as no questions, we move to the next speaker. Our next speaker is Dr. Khalid Al-Dehli. He's a senior consultant, clinical and biochemical genetist at Sultan Qaboos University Hospital. He is a fellow of the Royal College of Physicians and Surgeons of Canada, Medical Genetics 2009, and a fellow of the Canadian College of Medical Genetics, Biochemical Genetics 2012. And Dr. Al-Dehli has an active clinical research portfolio with approximately 70 publications in high-impact journals. He leads multiple research projects and serves as a reviewer and editor board member for several national and international peer-reviewed journals. تفضل دكتور خالد.
Assalamu alaikum. Thank you very much, Dr. Najat, for the presentation. And I'd like to thank the organizing committee as well for inviting me to be part of this event. I hope my voice is clear and I hope my slides are clear. I know that this is a long stretch of lectures today, and I can feel how the audience would feel like. So I'll try to be light when it comes to the topic that was assigned to me to talk about. And what I'll be talking about today is a topic that is titled Unmasking Gaucher Disease, Shedding Light on a Rare Genetic Condition. Gaucher disease, of course, is indeed a rare genetic condition, but we think it might be under-recognized in our region and globally, and it would be worthwhile to shed some light on this condition. I have nothing to disclose as far as this presentation is concerned. So Gaucher disease was named first after Philippe Gaucher, a hematologist whose PhD actually was focused on a woman in her early 30s who presented with massive splenomegaly. And at that time, he thought that she may have had some sort of splenic malignancy. And of course, we know that now Gaucher disease is caused by deficiency of an enzyme, which is called glucocerebrosidase, also named as beta-glucosidase, that leads to accumulation of lysosomal products, which are called glycosphingolipids, glucosylceramides, And the accumulation of this leads to a number of clinical sequelae that we encounter in patients with Gaucher disease. The enzyme itself requires an activator, which is called saposin C, and deficiency of saposin C or glucocerebrosidase would lead to similar clinical characteristics seen in patients with Gaucher disease. The accumulation of glucosyl ceramides in different cells, particularly macrophages, would lead to this crumpled tissue appearance that Dr. Zainab has already talked about in patients with Gaucher disease, which is in fact a hematopathological hallmark in this condition that we don't have to see nowadays before making a diagnosis because it can be made clinically on clinical grounds. So when it comes to different clinical manifestations of Gaucher disease, they're largely caused by the accumulation of glucosylceramide substrates in target cells, particularly macrophages and various tissues. So the accumulation of these cells in the reticuloendothelial system, the liver and spleen would cause the massive hepatosplenomegaly. A patient with type 1 would have massive splenomegaly. That's usually how they would come to our attention early on. And of course, accumulation of the glucosylceramides in Kupffer cells sparing hepatocytes would lead to the significant hepatomegaly, but not the entire visceromegaly is attributed by the accumulation of these substances. Sometimes there are sequelae of pro-inflammatory mediated changes that would also lead to associated contribution to the organomegaly we see in these patients and to additional manifestations. We also see significant bone involvement in patients with Gaucher disease, and that's because of the infiltration of these macrophages to the bone marrow. And so we see these responsible to the osteopenia, vascular necrosis, osteoporosis over time, and sometimes patients with Gaucher disease may have chronic dull pain that is associated with it. If you do X-ray, then you could see the Erlenmeyer flask appearance that you see over here because of the endogenous infiltration of the marrow with these cells and the accompanying osteopenia. So that's the another classic finding you see in patients with Gaucher disease. Infiltration of the lungs with the macrophages laden with the glucosylceramides would lead to the interstitial lung disease. Usually this happens progressively over time, but it can be severe as well in childhood. So these are the main clinical manifestations as explained by the underlying primary pathology. And in this slide, I'll talk about the overall three categorical types of Gaucher disease that we know of clinically, largely because of one primary distinction, which is essentially speaking whether there is a central nervous system involvement or no central nervous system involvement. And when there is central nervous system involvement, the course would determine as to what type of Gaucher disease it is. So the mildest form with no CNS involvement is the type 1 Gaucher disease. We call it the non-neuronopathic form of the disease, and that's basically associated with the visceromegaly and associated complications, hematological abnormalities, myeloid suppression-related presentation, and of course, by definition, type 1 Gaucher disease would have no neurological involvement. The type 3 Gaucher disease is a type that is associated with a slowly progressive disorder with associated neuronopathic forms of the disease, meaning neurological manifestations, usually starting with the horizontal gaze abnormalities, subsequently evolving into developing progressive myoclonic epilepsy and seizures, and eventually they die because neurological manifestations and progression of the disease. The most drastic, rapid form of the disease is the type 2 Gaucher disease, and these patients present with acute neuronopathic form presentation. They have a severe hepatosplenomegaly, severe pancytopenia. They die early on because of severe neurological manifestation and absence of treatment. They're typically dead by the age of 2 years, and unfortunately, these children and infants cannot be salvaged with any form of therapy available that we know of. There are rare forms of presentation where Gaucher disease can present. One of them is the collodion skin abnormalities and axiosome changes. So the skin becomes ectotic, and there's significant hydropic changes with the fetus. This is associated with perinatal lethality. And there is another variant of Gaucher disease that is associated with cardiac calcification. This form is not really common globally, but we see it in some part of the region. So essentially speaking, Gaucher disease presents as a clinical manifestation at the milder and a continuum of spectrum. At the milder end of the spectrum, your patients may become completely maybe asymptomatic before they display clinical manifestation later on. So a patient with homozygous non-neuronopathic form of a mutation may not really have symptoms of disease related to Gaucher type 1, but may be picked up only later on follow-up. But patients could also be as severe as presenting with perinatal lethal hydrops fetalis. And in between, you have different manifestations and complications of the disease that I'll describe also in the next slide. So these are the initial clinical presentation. What we have been struggling with when it comes to managing patients with Gaucher disease is the increased risk of malignancy, particularly multiple myeloma. This is a risk that is unfortunately not mitigated by the current available therapies, and it's something that we would have to keep in mind. Not many pediatricians would deal with it in early childhood because this is a complication that may happen later on. These patients also could have monoclonal gammopathy of uncertain significance, and they can have different forms of polyclonal gammopathy, and they need to be monitored for these. There's also an increased risk of Parkinson's disease in patients with Gaucher disease. It's very significant in homozygotes, but it's also seen in the parents of patients with Gaucher disease. The risk of heterozygotes may actually be increased by 2 to 3 folds compared to the background risk in the general population. I know that this is largely a crowd that is non-geneticists, so I'm not going to go into the details of the various type of mutations. I think it suffices to know that there are common mutations that we see in affecting the gene implicated in Gaucher disease, and that's named GBA. The commonest mutation that we see are these 4 mutations. That's the name that they're historically known with. And of course, they explain more than 90% of mutant allele in the population where this disorder is common. That's the Ashkenazi Jewish population. And they do still contribute to more than 50% of patients with Gaucher disease diagnosed globally. So they're important to recognize, and sometimes it may be useful to know about because they actually carry prognostic implications. For example, a patient who has at least one mutation of the N370S in GBA will not manifest the neuronopathic form of the disease, meaning at least that patient would have only visceral and hematological manifestations and bone manifestations, but would not develop neurological complication of the disease. The L444P mutation is usually associated with a severe disease course, if not accompanied by another milder mutation like the N370S. If there is a good reason why this presentation should be presented in this specific platform, it's because, in fact, hematologists are the primary specialists that make the diagnosis of Gaucher disease. They're the first liners who actually deal with Gaucher disease suspected patients. That's where initially patients typically get evaluated, and that's largely because of the fact that initially most of these patients present with splenomegaly, particularly thrombocytopenia, with hepatomegaly and anemia. And of course, these are the commonest presentation that would bring the patients first to medical attention. And it's no surprise that hematologists continue to be the first primary specialty that actually faces the initial evaluation of a patient's suspected Gaucher disease. They are the first specialty also eventually who would make the diagnosis. It's not geneticists, are not biochemical geneticists, and they're not the molecular pathologists. They are the hematologists who, truly speaking, would be the first specialty that would make the final diagnosis. And most patients with Gaucher disease usually would be diagnosed within the early childhood, below the age of 18 years. In fact, nearly 40% of them would be diagnosed within the first 9 years of life. All right, so establishing the diagnosis, suspecting that would be clinical, establishing it would be hopefully relatively easy. It's a dry blood spot that we actually collected for enzymology testing. And once you show a deficiency of the beta-glucosidase or glucocerebrosidase enzyme activity in dry blood spot, once the card is punched, then you can actually confirm it with a genetic diagnosis. I think the role of genetic diagnosis in patients with Gaucher disease would be largely for career testing, but also for prognostication of the disease and stratification of some of these patients into whether they have neuronopathic form of the disease or non-neuronopathic form of the disease. Sometimes we may face a patient who is clinically suspected to have Gaucher disease because of one reason or another. You aggregate clinical manifestations. You see the very classic clinical manifestations, and then you measure the enzyme activity, but the enzyme activity is negative. The enzyme activity is negative, or genetic mutation testing for GBA mutation is also negative, or it's not showing the disease-causing mutations in a patient with Gaucher disease clinically suspected. Then think of saposin C deficiency. Saposin C is, as you may recall, is the activator of glucocerebrosidase, and it needs to be thought of in this context. Sometimes the misassignment or mislabeling of a patient with Gaucher disease would stem from the fact that this suspicion was supported by a pseudo-Gaucher cells. You would recognize that pseudo-Gaucher cells would actually look like Gaucher disease cells, but of course they're seen in different other conditions like ALL, multiple myeloma, myelodysplasia. They can be seen in Hodgkin's disease and disseminated mycobacterial infection. There's another differential diagnosis Dr. Zainab earlier mentioned in her presentation, and that's basically acid sphingomyelinase deficiency, she referred to as Niemann-Pick. And of course, acid sphingomyelinase deficiency deserves particular attention when it comes to differentiation between ASMD and Gaucher disease, largely because of the significant overlap between Gaucher disease and ASMD. Both of these conditions will present with slowly progressive organomegaly, different degrees of pancytopenia. Thrombocytopenia is common with both of them. They both would have significant bony involvements of the clinical characteristic that I have described. And what distinguishes ASMD from type 1 Gaucher disease is the fact that in patients with ASMD, typically we would have associated hyperlipidemia that you do not see with Gaucher disease. And usually the lung involvement, the interstitial lung disease, is far more severe in patients with ASMD compared to Gaucher disease. And of course, the cirrhosis and liver fibrosis related abnormalities are more frequently seen with ASMD as opposed to patients with Gaucher disease. However, it's important to keep in mind if that usually labs that would measure the enzyme activity for the Gaucher disease would also concurrently usually measure the acid sphingomyelinase enzyme activity, both as a control, but also to rule it out simultaneously at the time you evaluate for the possibility of Gaucher disease, meaning usually the setup in the lab would be to concurrently measure both enzyme activities in addition to a standard control enzyme activity. So that's about clinical manifestations. That's about the various types of Gaucher disease that we know of clinically. And that's about how do we recognize these patients and how do we distinguish them from other differential diagnoses. And now we will be moving into talking about the various therapeutic options available for patients with Gaucher disease. I think our patients with Gaucher disease are fortunate because now we actually live in the era of therapeutic options when it comes to treating patients with Gaucher disease. So if we go back to the first slide where we talk about the deficiency of the enzyme activity, then the biological sense of treating these patients with Gaucher disease would come from making this enzyme available if possible, and that's through enzyme replacement therapy. The other option that is also available would be to inhibit the synthesis of the accumulating substrates, which is the lysosphingosine or glucosylceramides. If we inhibit this substance through a substrate inhibition therapy, which inhibits the glucosylceramide synthase enzyme activity proximal to the synthesis of the substrate, then you would cause a reduction of the accumulating substrate and therefore would mitigate the clinical manifestation of the disease. So largely speaking, up until now, the currently established therapeutic approach towards treating patients with Gaucher disease has focused largely on enzyme replacement therapy and substrate reduction therapy. And now we have different options available for patients with Gaucher disease. So adults would have different forms of enzyme replacement therapy, usually prepared differently. There is the imiglycerase, velaglycerase, and taliglycerase. The name differently produced by different companies through different recombinant DNA technology and different methods. Children would have only ERT available, so that's basically these different forms of enzyme replacement therapy. However, adults also have the added option of substrate reduction therapy, that's iliglustat and miglustat. The advantage of substrate reduction therapy in theory is that the substrate reduction therapy can potentially cross the blood-brain barrier and therefore may have an impact on the CNS manifestation. This has not really been well established yet, but this is still under evaluation for other more modified forms of substrate reduction therapy. But the enzyme replacement therapy, unfortunately, the enzymes being macromolecules, cannot cross the blood-brain barrier, and therefore they have no impact on the central nervous system. When it comes to the chronic form of the disease, and that's type 3 Gaucher disease, we only have ERT available for these patients. And we hope that the upcoming therapeutic options for patients with the chronic neuronopathic form of the disease, and that's type 3, where therapy can be offered to these patients to mitigate their illness. Unfortunately, type 2, the acute neuronopathic form of the disease, usually they progress very rapidly and die before anything can be offered to them therapeutically with a significant impact on the outcome. The preparation of the enzyme replacement therapy, the various enzymes I talked about would differ through the way they are produced, either through recombinant DNA technology, through an enzyme that is extracted from various cells in the human, or using Chinese hamster ovary cell line. And of course, these are usually delivered as an intravenous infusion. Patients receive every 2 weeks, and they did show significant impact on the clinical outcomes. Given that Gaucher disease has been known for a long period of time, in fact, short-term and long-term clinical goals have been very well established. Most of the time, patients achieve normalization of hemoglobin within 1 to 2 years of therapy. Usually, patients who are non-splenectomized would achieve normalization or improvement of platelets more than 100,000 by 3 years post-therapy. Splenectomized patients achieve, of course, this target earlier. We emphasize on the attempt to avoid splenectomy in patients with Gaucher disease nowadays. We should aim towards having no single patient with Gaucher disease splenectomized, because unfortunately splenectomy would accelerate progression of other complications associated with the disease, including interstitial lung disease, but also increasing the risk of malignancy. So patients with Gaucher disease, these patients, we should try to avoid splenectomy unless there is life-threatening bleeding, which is also rare in these patients. Usually, the normalization of the visceral size, spleens, and liver would typically be associated, would be achieved by 2 years post-therapy, and the therapy also contributes to improvement of in the mobility and overall quality of life. There are long-term complications that we should keep an eye on. I've mentioned multiple myeloma as a risk. Most of these patients, in fact, come to our clinic showing monoclonal gammopathy of uncertain significance, and they need to be monitored. They may have associated, more commonly, they could have polyclonal gammopathies. And of course, they need to be monitored for how these would progress over time. We typically do this jointly with people of your contribution from the hematology side, because that's crucial to the overall long-term management of these patients, especially recognizing the limitation of the current available therapy. There's also a need to monitor these patients for other complications, including the risk of Parkinson's disease and Parkinsonism. They need to be monitored clinically on clinical examination and referred appropriately. Patients with type 3 Gaucher disease would require also additional management from the neurologist because of development of seizures. So these would have to be monitored over time as well. So what we have seen so far, knowing Gaucher disease for a long period of time, is that this therapy has been largely effective. Data published from the International Collaborative Group in Gaucher disease has shown that actually, in fact, all the clinical outcomes that have been measured, including hemoglobin, platelet count, spleen size, and liver volume, have been sustained over the past 20 years of patients with Gaucher disease being treated. with enzyme replacement therapy, and that's very reassuring. A couple of slides about our experience with Gaucher disease. We so far have been following more than 14 patients now actually with Gaucher disease. They come largely from the northern part of the country. Unfortunately, 4 patients have died. The Gaucher disease types that are actually seen in our cohort is in fact 50-50, so almost 50% of them type 1 and 50% of them are of type 3, and they're all coming from the northern part of the country. The 4 patients who have died, 2 of them have died with anticipated course of progressive myoclonic epilepsy in patient with Gaucher disease type 3. There was 1 patient who died with a very rapid acute neuronopathic form of the disease, and that's type 2 Gaucher disease, and 1 patient died with COVID-19 related complication. We presently treat 7 patients with Gaucher disease on enzyme replacement therapy. None of our patients has started substrate reduction therapy, and 3 patients, in fact, have not been following because of one reason or another. One of them, in fact, is not on treatment because of the fact that this patient was diagnosed with homozygosity for a mild mutation, and so far he is 9 or 10 years of age and has been clinically asymptomatic, but he is, of course, displaying the clinical and biochemical markers of the disease. The usual standard dose of the enzyme that is recommended is 60 units per kg. We typically tend to allow patients to grow out of that unit, and we don't adjust the dose per weight. Once the visceral and hematological manifestations are achieved, there is no evidence that actually a strict dose is associated with significant impact on the bone manifestations or complications, although there is some preliminary evidence to suggest that we may have to see whether, in fact, a higher dose would impact the bone outcome. I just mentioned a couple of examples that the story is not always rosy. We should always be careful about other contributors to response to therapy. These are 2 sisters I have diagnosed with Gaucher disease. Both of them are adult. One of them started to show beautiful response to enzyme replacement therapy. They have a type 1 Gaucher disease. They have shown, one of them has shown significant improvement with the platelet count. The other one, in fact, continued to depart from the clinical response. So while her sister managed to actually almost normalize when it comes to platelet count, she had significant blunting. And we thought of various possibilities, including ITP, which is a very well recognized complication in patients with Gaucher disease, although it's rare. The sister failed initially to respond to prednisone, then eventually, and the lyso-Gb1, which is a marker that we use to monitor patients with Gaucher disease, have been rising. Then eventually she was started on trombopag and showed beautiful response to the therapy in conjunction with the trombopag at that time. So we're now managing this patient as a patient with Gaucher disease type 1 with the comorbid ITP as well, which has impeded her therapy. I've said earlier that interstitial lung disease is usually mild in patients with Gaucher disease compared to acid-sphingomyelinase deficiency. These are 2 children, siblings again, with type 3 Gaucher disease who presented with severe interstitial lung disease, unusually severe compared to most of our patients, the other patients. They are homozygous for a severe mutation, that's the L444P, and they have shown significant failure to thrive with digital clubbing. They were investigated for another etiology that may lead to chronic lung disease, and in fact, no other etiology was found, including on whole exome sequencing and extensive pulmonological evaluations with chloride testing. So it's the severe lung involvement in these 2 siblings is in fact attributed to the severe Gaucher disease that they have. They were initially treated with the standard dose of imiglucerase. That's the enzyme replacement therapy that we use in these patients. And then subsequently, there was a report of patients with severe lung involvement who responded to increasing the dose. So we increased the dose in these patients, but in fact, did not really see significant remarkable improvement. And then my colleague, Dr. Fathia, started them on a molecular chaperone therapy, and that's called Ambroxol, which has shown some preliminary evidence that actually it may be associated with increased enzyme activity and may mitigate some of the severe complications associated with the disease. I'm not sure really we have seen significant remarkable response to ambroxol therapy in these two siblings. So clearly speaking, there are unmet needs in patients with Gaucher disease. So there is the lack of recognition of this disorder early. There's significant diagnostic delays. And of course, sometimes the therapy may not be available because of the price. And if it is available, then we don't know which one would be the best. There's no longitudinal follow-up of head-to-head comparison between all of these available therapeutic options. There is limited data on the impact on the quality of life in these patients. And we do not know how substrate reduction therapy would actually impact other associated morbidities. The therapy, unfortunately, up until now, in the current doses and forms, they don't seem to impact the bony disease load significantly in these patients. And of course, we also have limited ability to control other potential risk and complications like multiple myelomas, the issues associated with increased risk of Parkinson's disease, and there's limited data availability on the long-term complications. Perhaps the most challenging aspects when it comes to managing patients with Gaucher disease is the fact that we don't have anything to offer patients with Gaucher disease type 3 when it comes to their neurological manifestation, which tends to actually progress and continue over time. So that is something that has been painful with when treating these patients, because they respond in a standard way to when it comes to the visceral and hematological manifestations. But unfortunately, their neurological manifestations are not prevented with the enzyme replacement therapy, which brings me to my conclusion slide, which is the fact that Gaucher disease is in fact now the most common lysosomal storage disorder. It's recessively inherited. It may be rare, but it's certainly under-recognized and underdiagnosed. And of course, it may be common in some population because of founder mutation. Patients usually are recognized initially based on presentation of splenomegaly and thrombocytopenia. And it's important to make diagnosis early because we can initiate a treatment that can prevent multiple morbidities in these patients. And of course, there are limitations to the current existing therapy that we try to hope, and with that we hope that they can be addressed in the future. That's it for my talk. Thank you very much for listening. And I welcome any questions.
Thank you so much, Dr. Khalid, for this excellent presentation of Gaucher disease, which is, as you said, it's a challenging disease and is underdiagnosed. This is why we keep talking about it, and we keep also the screening patients who are already diagnosed, like hemoglobinopathy is common in Bahrain, like in Oman. We do screen our sickle patients and thalassemia for the Gaucher disease just to rule out the co-inheritance or coexistence of both diseases in the same patient. As you know, sickle cell disease, it has many manifestations, which is similar to Gaucher disease, like the bony problems and the hepatosplenomegaly, the anemia. I mean, thrombocytopenia, it can sit in as a complication, but I mean, with many manifestations in common. This is why we do screen patients, at least with the filter papers, just to rule out Gaucher disease. Thank you so much, Dr. Khalid, for joining us. Now we move to the next speaker. Our next speaker is Dr. Lubna Azzajdali, is a seasoned consultant in hematopathologist at the Sultan Qaboos Comprehensive Cancer Care and Research Center. She earned her hematology fellowship from the Royal College of Pathologists in Australia in 2011. With over 12 years of experience, Dr. Azzajdali has led key initiatives in diagnostic, test implementation, validation, quality assurance, and laboratory management. Welcome, Dr. Lubna.
Assalamu alaikum. Thank you, Dr. Najat, for inviting me for this excellent conference. I'm starting my presentation about red cell revealing of autoimmune hemolytic anemia in young patients. So in my presentation, I will have some word about autoimmune hemolytic anemia, classification, the clinical presentation, and long-term complication. I will emphasize more in the diagnostic workup and some challenges related to it. And I'll briefly outline the treatment options with more overview of transfusion therapy, and I will conclude with some perspective. So this is abbreviation. I'm going to use it in my presentation. And as you know, the autoimmune hemolytic anemia is an uncommon condition in children with incidence ranging between 0.2 to 0.8 per 100,000 children. The incidence of female predilection increases with increased age, and it is characterized by development of autoantibodies directed against erythrocyte antigen. The development of autoimmune hemolytic anemia is associated with dysregulation of central and peripheral self-tolerance and the presence of autoreactive T and B cells. In the pathogenesis of the autoimmune hemolytic anemia, all components of immune system, autoantibodies, cytokines, the complement system, phagocytes, B and T lymphocytes, including cytotoxic CD8, T cells, and CD4 T regulatory cells, and natural killers cells play an essential role. The IgG-mediated autoimmune hemolytic anemia is most common in the children, while the IgM-mediated is less common. So the classification of the autoimmune hemolytic anemia, I think most of you know it. It's classified to warm antibody autoimmune hemolytic anemia, and the cold antibody autoimmune hemolytic anemia, plus paroxysmal cold hemoglobinuria. And you can have mixed warm and cold antibody autoimmune hemolytic anemia. Each of these categories are classified to primary and secondary. So for warm reacting autoimmune hemolytic anemia, the primary actually is idiopathic for all of them. However, the secondary causes commonly seen with lymphoproliferative disorders and some autoimmune disorders like SLE and chronic inflammatory disease, like ulcerative colitis, immune deficiency disorders, Evans syndrome, and it might be related to certain drugs. For cold reacting autoimmune hemolytic anemia, the secondary causes, again, it could be related to lymphoproliferative disorder, but commonly it's infections and mainly with the mycoplasma pneumonia and Epstein-Barr virus. For paroxysmal cold hemoglobinuria, the secondary causes is most commonly seen in children, which is related to viral syndrome, and congenital or tertiary syphilis is seen less or rarely in children. And the mixed type autoimmune hemolytic anemia has no further classification. So I'll just go with the case presentation of 6-year-old male who presented with 3 days history of fatigue, dark urine, pale appearance, with no significant prior illness, no family history of hematological disorders. In clinical examination, he was pale with mild jaundice, mild hepatosplenomegaly, and the heart rate was 120 tachycardia, but his BP was normal, and there is no lymphadenopathy or purpura was seen in the clinical examination. His lab results shows that his hemoglobin is low, 6.5, with reticulocytes high of 6%. The hemolytic marker of LDH and bilirubin is high, with the haptoglobin was undetectable, and the direct COMP test or direct antiglobulin test is positive. With the peripheral smear, you can see here the spherocyte present and the RBC, and this is and some reticulocyte count. Reticulocytosis, and this was mainly seen in autoimmune hemolytic anemia with positive DAT. This confirmed the diagnosis of warm autoimmune hemolytic anemia. And this patient was given initial treatment with IV methylprednisolone, folic acid, and packed RBC transfusion, and was monitored by checking his hemoglobin trends and any signs of steroid response by raising hemoglobin and lowering his LDH. For this case, there was a challenge in during rapid hemolysis that there is a need for urgent transfusion and the high dose of steroid side effect, and if there is a need for prolonged tapering, and of course, psychological impact on child and family. And the outcome of this case was that he responded very well to steroid, hemoglobin stabilized at 11 within 3 weeks, currently on tapering dose, and there's no relapses after at 3-month follow-up, and he go back to school. It seems very easy, straightforward case, which is we hope everybody of us, we hope that we find it in our clinical practice. But it's never been like this all the time. And usually we don't face, we face such straightforward cases, but usually we face some with challenges. So I'm going in details on I'll give you some information about this autoimmune hemolytic anemia pathophysiology in all the 3 classes. And we'll go through some challenges in diagnosis and how we can overcome it to reach the diagnosis of such patient and give him the appropriate treatment. The most common autoimmune hemolytic anemia is the warm autoimmune hemolytic anemia, which accounts for 60 to 70% of the autoimmune hemolytic disease cases. And the autoantibodies are typically polyclonal pan-agglutinins directed against common red blood cells antigen. These antibodies attack RBC at about 37 degrees and destroy them. The IgG-coated RBC are recognized by the splenic macrophages, which carry the Fc receptors for IgG heavy chain and lead to phagocytosis of RBC. Splenic macrophages remove a portion of RBC cell membrane, resulting in the formation of the microspherocyte that we are seeing in the peripheral blood smear. These microspherocytes are less flexible than the normal RBC, and they are trapped in the splenic sinusoids, resulting in the extravascular hemolysis. So this is the diagram showing this pathophysiology, where the IgG-coated RBCs are attacked by the macrophage and turn to the microspherocyte, and because of the shape of the microspherocyte, they are attacked again to be hemolyzed and causing extravascular hemolysis. The clinical manifestation for a patient with autoimmune hemolytic anemia warm type includes symptoms of anemia that we mentioned: pale, fatigue, jaundice, dyspnea on exertion. In severe cases, they can present with dark colored urine, and some of the patient can have splenomegaly. However, when the patient present with these symptoms, always we have to look for secondary causes that can present with symptoms that can show us that there is underlying illness like immunodeficiency, where the patient can present with frequent infections. Autoimmune hemolytic anemia also can be the first manifestation of SLE or associated other autoimmune condition like Sjogren disease, scleroderma, ulcerative colitis, as I said before, autoimmune hepatitis. So in clinical manifestation, always in the history and examination, we need to look at the detailed of these things to categorize, is it primary or secondary? And also drug history is very important to exclude drug-induced immune hemolytic anemia. The initial laboratory investigation start with complete blood count to check the low hemoglobin, of course, and if there is reticulocytosis, and increase mean corpuscular volume, MCV, which is related to increase the reticulocytosis. Peripheral blood smear is very important, where the hallmark to diagnose the warm autoimmune hemolytic anemia is the spherocytes, and it is differentiated from the cold one, where you have red blood cell agglutination. We'll come later to see it. And nucleated RBC in severe cases can present. So the third test, which is initial test, which is important, is the direct antiglobulin test, which is, if it is positive, is indicating that this is confirming the diagnosis of autoimmune hemolytic anemia. And if it is IgG type, it is the warm, and if it is IgM or complement, it's the cold type. Some additional test and investigation that might help. Of course, you will do the hemolytic markers in the test or the test, and you can add liver and kidney functions. And interestingly, it's very important to know the patient blood group. I'll come to tell you why. And also the red cell antigen profile is also one of the important things that you have to have it in your initial assessment for patient suspected with autoimmune hemolytic anemia. Of course, urine analysis for hemoglobinuria or hemosiderin, and coagulation ferritin iron profile. Also, if you're suspecting secondary causes, you can go with autoimmune workup, ANE, anti-double standard DNA, antiphospholipid antibodies, and so on. Also, to rule out infection screens, it's always recommended that any patient suspected with autoimmune hemolytic anemia to do the torch screen. And you can go with the flow cytometry if there is any clinical suspicion of lymphoproliferative disorder or immunodeficiency, and complement levels if your diagnosis is obscured and you cannot detect that there is a complement. The exact classification can go with the complement level as well. So this is the preferred smear for warm autoimmune hemolytic anemia, where you have these small microspherocytes. They lose their central pallor. They don't have the central pallor as a normal RBC, and you get more of these polychromatic cells, which is indicate increase of reticulocyte for this patient. This is this is neutrophils, but they are very activated, or they are with toxic granulation, which is also can help that. If there is secondary infection or something, we can get from the peripheral blood to help the diagnosis of secondary as well causes. And this is another slide for patient with cold autoimmune hemolytic anemia with the red cell agglutination. All their RBCs are clustered together. They are not separated very well. So a few words about the direct antiglobulin test, which is the main cornerstone for the diagnosis of autoimmune hemolytic anemia. As the principle, it detects antibodies or complement on RBCs, and positive that confirms autoimmune hemolytic anemia, but there will be some false positive can occur. So that is positive in 95 to 97% of individuals with warm autoimmune hemolytic anemia with anti-IgG, and anti-C3d, or both, while that is positive in less than 1% of general population. That's why the correlation of the history, clinical findings, and other blood tests is very important to interpret the data itself. And very important in direct antiglobulin test, not to perform the test itself to find it's positive or negative. It's important to have the titer that can correlate with the disease severity as well. So this is also can be performed in the blood bank. So in the blood bank, they have the direct antiglobulin test as polyclonal, which can be positive or negative. And then they can have the monospecific one. So very important when you request for that for autoimmune hemolytic anemia, if the blood bank shows, if the blood bank shows that the polyclonal is positive, they are immediately go to find out the monospecific one. But if there is a suspicion of case of autoimmune disease, autoimmune hemolytic anemia, and that was negative, it's very important to request from the blood bank to go with the monospecific part, because it can happen. I will come to this in my other slide. So with the DAT positive cases, the blood bank not only performing the monospecific, it's very important to do elution and to identify if there is any other underlying antibodies, because this can be misdiagnosed with the transfusion reaction cases, and they can be also mismask or mask the alloantibodies that is underlying the cause of the transfusion or the hemolysis. So whenever there is a DAT positive, there should be antibody identification tests done in the blood bank as well with the elution, which basically it's trying to release the antibodies that coating RBCs to be free in the serum, and then the elute, which is the serum that contain these free antibodies, are tested against donor reagent red blood cells to check if there is any antigen coated by this antibody specificity. Okay. So it's not uncommon to have that negative autoimmune hemolytic anemia, but it is mainly the most common cause is technical. So the chance of negative direct antiglobulin test in autoimmune hemolytic anemia is around 10%. If you use tube techniques, which is not any more used I mean, it's used in only emergency cases, but it's not used anymore in the practice of blood bank, and usually is less than 5% with gel cards and with low ionic strength solution. However, the false negative results can be due to IgA autoantibodies that are not detectable by the most routine reagents, and maybe can be because of low affinity of IgG, and can happen because of RBC bound to IgG below the threshold of the test. So in that case, we need more sensitive methods that like the microcolumn gel, solid phase, and flow cytometry method, as well as enzyme-linked antiglobulin immunoradiometric and mitogen simulation test to detect positive direct antiglobulin test. Also we can have that gel cards, which can contain a set of monospecific AHG reagent like anti-IgG, anti-IgG, IgA, IgM, and complement C3, C3C, and C3D. And this can be used to overcome the negativity of autoimmune hemolytic anemia, that negative autoimmune hemolytic anemia. Anyway, it's recommended as well if you have a case with that negative patient. It always should be investigated for hemoglobinopathy with high performance liquid chromatography and G6PD screening, and also flow cytometry to exclude PNH for those patients. If you exclude secondary causes, and you try to do more specific tests for that to exclude technical causes for negative autoimmune hemolytic anemia, we still have there is still 5 to 10% of cases of autoimmune hemolytic anemia with that negatives are labeled after exclusion of the secondary causes. So this is schematic diagram for the approach to a case with autoimmune hemolytic anemia. Of course, the triggering things to start this systematic approach, that there is evidence of hemolytic anemia, and with reticulocytosis, maybe spherocytes in the peripheral blood, LDH is high, indirect bilirubin is high, haptoglobin is low, and maybe this patient has hemoglobinemia or hemoglobinuria. So, as I said, the cornerstone is to do the direct antiglobulin test. If it is positive, that's nice. So you just go to clinical assessment, rule out other differential diagnosis, and then if there is no other differential diagnosis and it is confirmed to be autoimmune hemolytic anemia with positive direct antiglobulin test, is it IgG only or is it complement CD3D? So if it's IgG, it's a warm autoimmune hemolytic anemia, very straightforward. But if it is and if it is complement, it goes with the you need to do direct antiglobulin test screen at room temperature and antibody titer. And if the titer is more than 64, you called it with the cold agglutinin disease. If only it was the complement C3D. But if it was mixed between complement and that is complement and IgG, it is you need more further clinical and surgical assessment, and can be cold agglutinin disease as well. You can label it as mixed autoimmune hemolytic anemia because of the presence of IgG with the complement. So what is the current treatment option for the warm autoimmune hemolytic anemia? The first line of treatment is corticosteroid, and the response rate is very high, up to 80%. Usually the cases are the response appearing in the first week. Relapse correlates with increased duration between the onset of symptoms and treatment. A recent study has identified that children with type O blood group, MCHCV value of 0.161 have a higher risk of early recurrence. That's why it's very important to know the blood group for this patient in the initial assessment when I mentioned in the beginning of my talk. Transfusion therapy is the it's can be avoided as much as possible. Why? Because we want to prevent more induction of antibodies. But there is currently there is no different hemoglobin cutoff value to be used for transfusion in this pediatric age group. Only if there is impending congestive cardiac failure or high rate of fall of hemoglobin, then the transfusion is used. The pan-agglutination that is caused, that has been seen in the warm autoimmune hemolytic anemia because of the autoantibodies, mask the underlying alloantibodies. That's why I mentioned that we need some elution and workup to rule out there is no underlying alloantibodies. And as it's known, 30% of the antibodies detected in the warm autoimmune hemolytic anemia belong to the IgG class and have specificity for Rh antigen. So provision of prophylactic antigen matched donor blood, which is for Rh matched antigen, it will be the best for those patients. However, if there is emergency need for the blood, the least incompatible red blood cells can be given, just to ensure that these units of that blood units are given with are leukoreduced, and they are used with proper hydration and close monitoring when they are transfused to those patients. The second line therapy include IV immunoglobulins, rituximab, splenectomy, some of the treatment like cyclosporine, azathioprine, and mycophenolate mofetil is used. The utility of the plasma exchange is limited to occasional cases and reports. There is variable outcome for the use of plasma exchange in warm autoimmune hemolytic anemia. However, in severe or life-threatening cases, it shows no response. Now, for the cold autoimmune hemolytic anemia, which is account 20-25% of autoimmune hemolytic anemia cases, as you know, the most cold antibodies are IgM antibodies and rarely IgA or IgG, and most cold antibodies has specificity for I carbohydrate antigen present in every one older than 18 months of age. So the antigen-antibody complex, which is formed in acral parts of the body, like the fingers, ears, and nose, induced a complement binding and activation via the classical pathway, and which can be manifested when we see the patient with Raynaud phenomena. And with this IgM bind C1q on the red cells membrane, activating the classical complement pathway, but dissociating from the red cells centrally, leading to direct antiglobulin test that is characteristically positive for only C3d. When the blood returns to the central parts of the body, which is warmer at the 37 degree, the cold antibodies detached, allowing the agglutinated RBC to separate while the complement C3b remains bounded. Because of that, extravascular removal of C3b coated red cells by reticuloendothelial cells is activated and leading to intravascular hemolysis. Children present with cold autoimmune hemolytic anemia usually are living in colder climate. They can experience cold-induced ischemic symptoms like cyanosis of area of distal body parts, like the tips of the ears, nose, and the digit. And you can suspect it with those who has cold-induced symptoms with unexplained hemolytic anemia, and they present with RBC agglutination in a cold blood collection tube or in the peripheral blood smear. Most cold autoimmune hemolytic anemia in children are secondary to infections and are self-limiting. Patients with lymphoproliferative disorder, usually adults, may have a chronic hemolytic state till primary cause is resolved. So the gold gold stone to diagnose the cold agglutinin disease beside the preferred smear and the clinical presentation is the cold agglutinin titer and cold agglutinin titer. It measures the concentration of cold agglutinin. Specificity is typically anti-I or anti-little I, imported in suspected cold agglutinin, called autoimmune hemolytic anemia. The cold agglutinin titers are usually high, and accepted threshold for diagnosis is 1 to 64. The pathogenicity of the cold agglutinin is more dependent on the thermal amplitude than on the titer. So very important when they test for this titer in the blood bank, you ask about the thermal amplitude at which temperature the reaction happened. So this can give you a clue how is the severity of the disease is and how is the manifestation will be approximately in vivo. So the management for the cold antibody autoimmune hemolytic anemia, majority of episodes are transient. Factor BC alone may be sufficient without specifying the specific therapy. Most of the cold autoantibodies, as I mentioned, that is directed against I antigen. In blood bank finding IN negative donors unit is extremely rare, but you can give a compatible blood unit and generally, and it is safe for those patients. With use of the inline blood warmer, just to prevent the destruction and to safely give the units for the child. The supportive measures include avoiding exposure to cold and keeping the body euthermic is very important. There is a study shows that erythropoietin can help reducing transfusion requirement in 70% of patients. And if the patient has secondary cause like infection, appropriate microbial therapy or antibiotics can help in eliminating the cold autoantibodies. Steroid and immunosuppressive agents are often ineffective in cold antibody autoimmune hemolytic anemia, and splenectomy does not have a role in managing this condition. Rituximab generally first-line therapy when indicated, but it shows partial response in about 50% of the patient. The complete response was rare. Plasmapheresis in cold antibody autoimmune hemolytic anemia is effectively removes autoantibodies in children with severe disease, likely because cold autoantibodies IgM class are virtually all located intravascularly, so it's easy to remove it. And it is accepted, the plasmapheresis is accepted as a second-line treatment, either standalone or in conjunction with the treatment modalities, other treatment modalities. This is the treatment options that has been used in adult and need further investigation in children. So in summary, this is the type of the autoimmune hemolytic anemia. What is the immunoglobulin class that you find in each one? The warm you get IgG, and rarely IgA or IgM. So most commonly IgG, and the complement fixation only in few. Temperature amplitude they react with at 37 degrees, and the antigen specificity, there's no antigen specificity, it's pan-reactive, but as I said, because it is mainly IgG, the RH system is very important to give the RH system because it's IgG, it can be involved. However, we recommend always to give RH matched units for those patients with warm autoimmune hemolytic anemia. And again, as I said, that positivity is more for IgG, but can be IgG and the complement as well. The cold antibody autoimmune hemolytic anemia, it's mainly the immunoglobulin class is IgM. Complement fixation is common, and it's react at 4 degrees. And the antigen specificity which is involved is the I and little I system. And it's all the time, it's the data is for IgG is negative, while it is positive for the complement. However, if you have the cases like that, we can consider it is mixed, okay? The The paroxysmal cold hemoglobinuria, okay, it's biphasic IgG, and the complement fixation is common, and it's ranked at 4 degrees, but hemolyzed at 37 degrees. Okay, and it's involved the P antigen, and the diagnosis by the positive Landesteer test. Again, the mixed autoimmune hemolytic anemia, they have IgG and IgM. And again, the complement fixation only in few. It's act at 4 degrees and 37 degrees. That's why it's mixed. And the parareactivity usually lacks specificity of warm IgG. Cold antibodies differentiate differently, and it has the both IgG and complement. For the drug-induced IgG autoimmune hemolytic anemia, it's often Rh system, is not related to any of those, and it's either IgG or with the complement. Just a few words about paroxysmal cold hemoglobinuria. It's very rare hemolytic anemia in children, and the term itself is misnomer, as hemolysis is rarely paroxysmal, usually has no relation to cold, and hemoglobinuria is not seen in all patients. However, the name is given as it is, and we keep using it. Most of the data is based on case reports and case series. No large study exists, but annual incidence is estimated to be 0.04 cases per 100,000 person. The paroxysmal cold hemoglobinuria may be underdiagnosed due to its transient nature and lack of awareness about its diagnosis. However, infections, especially viral, are the predominant cause of the PCH in children, while the syphilis is the commonest cause in adults. The syphilis is very rare in children to cause PCH. So the diagnosis should be suspected in children who develop symptoms after cold exposure with signs of intravascular hemolysis, where they lack of red cell agglutination in peripheral smear, and they have positive DAT for complement, but they are negative for IgG. And the assay detects a biphasic hemolysin called Landesteer antibodies that bind to RBC in the cold, fix complements, and dissociate upon warming. Results may only be positive for high titer antibodies during a relatively short period of hemolysis. And for treatment, does not require specific therapy, and most children improve within a month. Largely the treatment is supportive. However, for acute hemolysis, packed RBC transfusion may be required. In one of the systemic analyses suggests that 70% of patients require a medium of 2 units packed RBC transfusion. That's enough for them. For DL antibodies, it is specific to P antigen on the surface of RBC. However, the penal RBC units are very rare, so transfusion of P antigen positive cells has not led to increased hemolysis. I mean, we don't have it's very rare to have penal RBC, and the studies that has been, or we used to give the P antigen positive cell to those patients with paroxysmal cold hemoglobinuria, but there is no issues with the hemolysis. Wash RBC are often are of no advantage, but is practically some of the clinician is requesting it, but it has no advantage. Excessive cooling is to be avoided. The utility of keeping the child warm or using that warmer for the paroxysmal cold hemoglobinuria during the transfusion is unclear, but it is one of the usual practice. The natural history of the PCH hemolysis is unpredictable, and therefore the effectiveness of such intervention is difficult to interpret. Corticosteroids are often administered, but the efficacy is not known. A case of IgA-associated PCH has been reported where steroid did not have any response. As per the clinical data available, the median stay in the hospital was 13 days and did not differ concerning steroid use. In severe cases, plasma apheresis may transiently control hemolysis. And there is a case report of 4-year-old child has been reported who was successfully treated with complement inhibitor clozimab, but there's no other large study to support this. The recurrence of the paroxysmal cold hemoglobinuria is rare, and the proper diagnosis of it prevents unnecessary therapy. I'm just ending with this review article from by Zhang. It's a childhood autoimmune hemolytic anemia scoping review. The review search in midline and the coherent central trials registered from 2000 to 2023. Experimental and observation studies reporting of autoimmune hemolytic anemia, diagnostic criteria, laboratory workup, or treatment management in populations with at least 20% of patients aged less than 80% were included. 43 studies were included with no randomized controlled trials identified. The result of this review shows that the diagnostic criteria and tests of autoimmune hemolytic anemia were highly variable across studies. And the first-line treatment used approach was including mainly the corticosteroid, IV immunoglobulins, or both. The resistant to first-line therapy, the approach to autoimmune hemolytic anemia resistant to the first-line therapy were widely variable between studies, but most commonly include rituximab and or cyclosporine. So the conclusion of this review identified a heterogeneous group of observational studies into this complex immune-mediated disorder. Standardized definitions and classification are needed to guide collaborative effort to study this rare disease. The work done by the Caravans group provide an important paradigm for future study. So we are there's no consensus about the diagnosis and the treatment for this autoimmune hemolytic disease. Just to enlighten the new insight on the diagnosis of the autoimmune hemolytic disease, there is some advances in molecular testing, including genetic analysis to identify mutation in complement regulatory protein. New biomarkers like soluble CD163 and C-reactive protein are being researched. These predicted disease severity and response to treatment. Flow cytometry is used to detect complement deposition on RBC, and that's the new approaches to help an appropriate diagnosis. So, in summary, a comprehensive lab approach is vital for accurate autoimmune hemolytic diagnosis. The direct antiglobulin test remains the key diagnostic test. Evaluating secondary causes is also crucial for effective treatment. Performing a direct antiglobulin test and antibody identification can be technically challenging. With a full understanding of the clinical scenarios, transfusion medicine may be able to optimize testing. Collaborating with transfusion medicine in the diagnosis and management of autoimmune hemolytic anemia is also critical for treatments such as transfusion or plasma apheresis. This is my references, and by this I thank you for listening. And if you have any question, let me know.
Thank you so much, Dr. Lubna, for the excellent presentation. I don't see any questions, so we'll move to our next speaker. The next speaker is Mr. Khaled Al-Habaiba. He is the Unit Manager, Pediatric Hematology Oncology Unit, Tawam Hospital, United Arab Emirates. Khaled, he's actively involved in hemophilia care, serves as nurses committee member for the World Federation of Hemophilia, and as General Secretary and Hemophilia Nurse for the United Arab Emirates Hemophilia Group. Please, Dr. Madri, please, Khaled.
Yes, assalamu alaikum. Good afternoon, everyone.
Alaikum assalam wa rahmatullah wa barakatuh.
So, Dr. Najat, thank you so much once again for giving us this opportunity to be part of this international conference. And it gives me a great pleasure to speak to you again today. Yesterday, I spoke about the nursing impact in hemophilia care, and today I'm going to speak about the nursing impact on thalassemia care. So this is my objective today. I'm going to give just an overview about thalassemia, which is from nursing perspective. I'm not going to dig deep into thalassemia and what's thalassemia. Then I'm going to highlight the role of nursing in managing thalassemia. And after that, I'm going to explore the impact of nursing lead initiatives on the overall outcome for thalassemia care in our region. So what's thalassemia? Thalassemia is a genetic blood disorder affecting hemoglobin production. Thalassemia is inherited disorders characterized by reducing or absent amount of hemoglobin, which is the protein in charge of carrying the X gene in the red blood cells. And we have two types of thalassemia. We have alpha thalassemia, we have beta thalassemia. The alpha thalassemia, it's result from deletion in one or more of the 4 alpha gene. Beta thalassemia trait, we call it a silent carrier, result from defect on single beta gene, while beta thalassemia major result from defect in 2 gene, cause chronic anemia and required lifelong care. Now, how we treat thalassemia? After confirming the thalassemia by a laboratory test, we confirm diagnosis. So the treatment is to initiate the blood transfusion. And the transfusion started when hemoglobin level dropped below 7 grams per deciliter, or depends on the clinical assessment. So sometimes we still proceed with the transfusion, even the hemoglobin, it's above 8, and it's all about the clinical manifestation on presentation for the thalassemia patients. And the aim of transfusion is to keep the hemoglobin level, it's around 11 grams per deciliter, but it should not be exceeding the 15, 14, or 14 grams per deciliter. And the transfusion takes place every 3 to 4 weeks, depends upon, the needs of our patients. Now, the characteristic of the blood bags, it should be maximum 7 days old, and it needs to be washed and irradiated. And why it's irradiated? This is a common question we received from our patients and families, even from the healthcare provider, why it needs to be irradiated. And this is to reduce the antibodies, especially for those patients who's planning for bone marrow transplant. This is going to reduce their a chance of rejection. Now, we have recent advanced treatment for hemophilia. So, for thalassemia. So thalassemia, it's genetic, leading to reduce the hemoglobin level, and the treatment is to give blood transfusion. Now, there is advanced treatment for thalassemia, which is bone marrow transplant and potential cure for younger patients, and the gene therapy, which is the innovation approach to correct genetic defects. And the gene therapy for thalassemia, it's promising. Recently, I think in August 2022, the FDA approved the first gene therapy for transfusion-dependent beta thalassemia. It's too early to have a result, but we are looking in a positive way for gene therapy to lead and to innovate the treatment for thalassemia patients. Now, if we look at the thalassemia, so we have a problem in our hemoglobin, and the treatment to transfuse with blood, and patients will be demanding on blood transfusion. Unfortunately, blood transfusion, it comes with risk, it comes with complication and side effect. So with recurrent transfusion, we're going to have an iron overload occur when the iron intake increase. So for thalassemia patients, the iron will be increased through the blood transfusion. Each blood bag, which is 200 or 250 ml, it has 200 or 250 milligram of iron. After a certain period of time, our body will be absorbed and overloaded with iron. And then we don't have a mechanism in our body to excrete the excessive iron, and the body become overloaded with iron, lead to formulation of non-transferrin bound iron forms in the plasma. And this is a very toxic formation of iron, has the capability to penetrate a vital organ, such as the heart, liver, endocrine system, which leads to more complication resulted from the iron overload. In order to excrete this iron overloads, we are using chelating factor. Chelating agents are used to manage the iron level, and we give it by oral or through IV administration. Now, the iron level we are aiming to, it's below the 1,000, but we're trying to keep it between 500 to 1,000. Now, thalassemia care, it's not a one-man show. It's complex, it's a multi-systemic and dynamic. required comprehensive management. It required a holistic approach to address all aspects of the disease. And it's highly demand in well-trained healthcare provider. Specifically, as I'm a nurse, I'm going to take from nursing perspective, it required highly trained nurses, which is essential for providing high quality of care, specialized care and support for thalassemia patients. And in order to be able to provide such comprehensive care, you need to have a certain knowledge and the skills to help you to support patients with thalassemia, to support a family of patients with thalassemia. Thalassemia care faced many critical gaps. This includes some of these challenges: access to care, access to comprehensive thalassemia center, blood product availability. Right, we are living in an area where the blood is being provided by the government, but in some regions and some countries, thalassemia patients, they need to bring their bloods with them. So imagine that the efforts and the suffering of patients, of thalassemia patients and their families to obtain and to provide their own the blood to be transfused for them. Additionally, the cost, even direct cost on the healthcare organization or the system or from our patients' pockets. And we have severe lack of support care for thalassemia patients. In addition to that, we have severe lack of thalassemia nurses. Now, the lack of thalassemia nurses contribute to suboptimal care, resulting in increased complication, poor quality of life for thalassemia patients. Thalassemia care, it's required specialized knowledge and skills due to unique challenges associated with thalassemia. Now, I'm going to speak about the role of thalassemia nurse in providing care for thalassemia patients and their families. So I'll start with the clinical management and monitoring. Blood transfusion administration, it's a part and vital part of the nursing job. Now, nursing ensuring a proper cross-matching, monitoring for transfusion reaction, documentation, whether it's pre, during, and post-transfusion, and educate patients' family about the sign of adverse events. Again, nurses also take a role in chelating therapy, administering and monitoring the efficacy and the side effects of chelating agents. Nurses also reinforce the adherence, as we all know that we have a compliance issue with the thalassemia patients, especially for pediatric and adolescent population. Also, nurses monitor for complication. They are following the routine assessment of the cardiac, hepatic, endocrine, and infectious complication due to iron overload or chronic anemia. Nurses often perform or coordinate a regular screening such as endocrine, echocardiogram, and liver function test for thalassemia patients. Second major part of the thalassemia nurses is patients and family education. Education is an essential component for thalassemia care and fundamental nursing responsibility. And again, nurses explain the importance of adherence to the iron chelating supplements and prophylaxis treatment. And they make sure that the patients maintain their appointments in a proper way in order to receive the transfusion in a proper time. And also they play a major role in genetic counseling, and with the formal counseling is provided by geneticists. Nurses help reinforce and understand of inheritance pattern, career states, and implementation of family planning. The third role of nurses is psychosocial support and advocacy. Living with a chronic illness has a significant psychosocial implication, particularly for children and adolescents. Nurses identify signs of depression and anxiety or social withdrawal and collaborate with mental health professionals to support patients and family during this phase. And also, nurses work with other healthcare providers to improve the quality of life for thalassemia patients by addressing the fatigue, pain, and school or work and accommodation. Nurses work as advocates for patients and their families within the organization, and they enhance and foster the concept of patient-centered of care. Culture competency, nurses, the most people who is really aware about the culture competencies for thalassemia patients for the community. I'll give an example. In UAE and regional contents, nurses must be sensitive to the culture beliefs, language leads, and stigma around the genetic disorders. The other function that nurses taking care for the thalassemia care, it's the care coordination and a multidisciplinary team involvement. As we agreed that thalassemia is not a one-man show, it's an MDT efforts and comprehensive efforts from all healthcare providers dealing with thalassemia community. So the thalassemia management required a highly coordination approach. The care coordination, nurse ensure communication between hematologists, endocrinologists, dietitian, and social worker, and schedule timely follow-up with all these services in order to keep the patients with thalassemia under, supervision. And here we create what we call nurse navigator. Now we have thalassemia nurse navigator who's really in charge and navigate the patient's visits within the organization, and she works as a link between patients' families and healthcare provider. Also, nurses coordinate the transition planning, where especially moving patients from pediatric services to adult services. Sometimes we face a lot of challenges. Most of our patients, they refuse. They get used to pediatric population. It's very hard for them to move to a new healthcare provider team, which is the adult team. But in order to overlap and overcome this challenge, the nurse thalassemia navigator create what we call a transition clinic, where we have the pediatric team and adult team seeing the patients in the last year before moving him to adult services. Nurses also contribute to a comprehensive plan addressing physical, emotional, and social dimension of care for thalassemia patients. Again, nurses play a major role in advancing, the thalassemia care. And some of the thalassemia center in the region and worldwide, they have a thalassemia practitioner nurse or what advanced nursing practice. Nursing specialized thalassemia center often expand the role through advanced practice. Nurses lead clinic. Now we have thalassemia practitioner nurses. They have their own clinic in some model of care, not across the world. I do understand we might have one or two thalassemia practitioner in our region, but unfortunately, the health authority does not recognize their certificate, so they still work as a navigator, but in fact, they are practitioner. In North America and Europe, they can open their own clinic, but still they are advancing and they are taking a lead in advancing the thalassemia care and the outcome. Nurses also, the practitioner nurse, they develop protocol. They experienced nurses develop and update clinical pathways, transfusions protocol, and emergency management guidelines for thalassemia patients. And they take a lead in training a new graduate nurses, other nurses to become a thalassemia nurses in their facilities. We have a couple of nurses who's really doing a great job by creating an education platform for nurses to become a thalassemia nurse. Now, again, definitely nurses, they don't work in silos, so they're conducting their own research and they really follow the evidence-based practice in order to improve their outcome and their practice. Nursing contributes significantly to improve thalassemia care through clinical audits, quality improvements projects. We have a lot of quality improvement projects for thalassemia patients leads by nurses. They monitor the transfusion appropriateness, adverse events, and documentation practice. Also, nurses participating in research study, nursing assists in patients' recruitment, data collection, and implementation of pilot intervention. And we have a lot of publication related to thalassemia care by nurses in our region. Now, nurses' comprehensive approach advance the thalassemia care and directly contribute to improve patients' outcome. Their role extends beyond the routine clinical tasks to encompass a comprehensive patient-centered care that address the complex need of individuals living with thalassemia. They reduce the hospital admissions, they improve patients' family satisfaction, and they enhance the disease management. And on top of that, they reduce the overall cost for the institution, which is our hospitals, and for the patients too. I want to summarize that nurses are central to effective thalassemia care, serving as a front line, providing in the delivery of safe, continuous, and compassionate treatment. Patients' education, psychosocial support, and clinical monitoring are core nursing functions that contribute to better disease control and quality of life. Collaboration, evidence-based approach, lead or coordinate by nurses, enhance care integration, reduce complication, and lead to improve patients' outcome. Last slide, I would like to recommend that expand specialized nursing training program in thalassemia care to enhance clinical competencies in transfusion safety, chelating management, and patients' education. And this is a call for all of you. And I believe that some of you take a lead in decision-making, policy-making in your institution to support the nurses to have a full FTE, which is a full-time nurse to take care of thalassemia. I know this model of care, it's not really recognized by most of our healthcare institutions in the region, but it deserves. We have very strong evidence that having a specialized nurses in thalassemia care can improve the overall outcome. We need to empower the nurses a lead role to influence the policy developments, care model, and quality improvement initiative within thalassemia service. Now, in order to have a specialized thalassemia nurses, we need to provide them with a protected time. We need to provide them with a financial support, giving them the opportunity to attend workshops, conferences, to gain more knowledge and information, to empower them to be a qualified, competent thalassemia nurses. And lastly, support nurses lead research focused on innovation, care strategies, patient-centered intervention, and long-term outcome improvements in thalassemia management. With this, I thanks again for giving me this opportunity, and I will be happy to take your questions.
Thank you so much, Khaled, for the excellent presentation. I agree with you. The nurses, they have a vital role in the thalassemia care because they are the closest person to the patient and his family. With that, we move to our next, as no questions, we'll move to the next speaker. Our next speaker is Dr. Amira Radi. Dr. Amira Radi has over 20 years of experience in hematopathology and transfusion medicine. She graduated from the College of Medicine of Arabian Gulf University, Bahrain, and holds fellowships in hematology from King Saud University and Royal College of Pathologists of Australia. Dr. Amira is a full-time consultant at Salmania Medical Complex, Bahrain's largest government hospital, and serves as part-time senior lecturer at Arabian Gulf University. And she is an active member of national and international professional societies and has served as General Secretary of the Bahrain Association of Pathologists. Please, Dr. Amira.
Good afternoon, and I hope my voice is hearable. Just confirm me. Yeah. I just want to start before starting my presentation to give you my deep thanks for Dr. Najat for her inviting me to present in this international conference and sharing our experience and knowledge with the different colleagues. So my talk today will be about the non-transfusion dependent thalassemia, and we will go on to a comprehensive reviews and novel approaches in regard to these thalassemia. First, I want to start with my disclosure. I have no disclosures. My first slide will be a repetitive of what my colleagues have tackled through to understand the thalassemia. So our main structure that is important in red cell, which is the hemoglobin, which composed of two parts, the heme, which is the profiles and the iron items, which is important in the carrying of the oxygens to the tissues and back the CO2 to the lungs. But the second part of the structure, which is very important here, which is the globulin part, which composed of 2 alpha and 2 beta chains. Going to the globulin controlling chromosomes that are scattered into chromosomes in chromosome 11, where we have the beta, delta, and gamma, and the epsilons, and the different expression of the globulin seen among the different life from the embryonic to the adult life, where we have the higher level of hemoglobin F in the embryonic and later in life after 2 or 3 months, where we decrease in the fetal hemoglobin and extending of the level of the beta globulin excretion, having the normal hemoglobin. And in chromosome alpha, where we have in chromosome 16, we have the 2 genes, which are the alpha 1 and alpha 2 globulin, and they are controlling the alpha globin production. Now, the type of mutation that we see in thalassemia are a vast majority, where we have starting with point mutation, with substitution, either it could be a silent or nonsense or missense mutations. And we have the frame shift mutation, where we have insertion or deletion of part of the frame. And then we have the duplication and repeat expansion. This is showing you the different mutation for the different genes that have been discovered. Now, associating the genotype with the phenotype of the alpha and beta thalassemia is important in our clinical management, where we have the alpha thalassemia, where, as we know, that we have 2 gene controlling the alpha gene, and there is a different clinical picture from silent to the hydrocephalus. And what is important here, as we are pointing the hemoglobin H disease, where we have the 3 gene deletion, and these patients will have moderately to mild to moderately anemia, and the different of the phenotype will be according to the different mutations. Then we go to the beta thalassemia, where we have the minors, the intermediate, the beta thalassemia intermediate with the beta plus or beta 0, beta plus, and the major, which is the severe with transfusion dependent thalassemia. The other entity where we have the hemoglobin E, and it is a range, but what we are concerned here in the transfusion, non-transfusion dependence is the hemoglobin E with beta thalassemia. And as we know that the homozygous, they are asymptomatic with usually border asymptomatic anemia, and they don't need any transfusion. So as from the previous chart, we can map the thalassemia into a minor or a very a thalassemia which does not require or seldom required transfusion, to a very major thalassemia which is transfusion dependent, and in between we have the non-transfusion dependent thalassemia, which we will tackle about. So non-transfusion dependent thalassemia are a group of thalassemia that are do not require a regular red cell transfusion for survival. However, these patients may require occasional or even frequent transfusion in certain clinical settings that we will discuss later. So the three components of main category, we have the beta thalassemia intermediate, the mild to moderate hemoglobin E beta thalassemia, and the alpha thalassemia intermediate, which is the hemoglobin H disease. There are two more entities that also have a similar transfusion requirement, and we are crossing when we are diagnosing or treating in the clinical setting, which are the hemoglobin S beta thalassemia and hemoglobin C beta thalassemia. So this is the range. Again, the minors, then we have the transfusion, non-transfusion dependent dependent thalassemia, and then the TDT, which is the transfusion dependent. So the diagnosis of these cases will come with a full medical history or a suspicious or a screening of high-risk families, having a CBC with a low MCV, low MCH, which is microcytic hypochromic anemia, and the presence or plus of the inclusion body by detection of HPH inclusions. If we have a normal serum ferritin, lower serum ferritin, so this will go in the direction of iron deficiency anemia. A patient with a higher level of serum ferritin, we will go and proceed to HP electrophoresis and HPLC. And looking to the patterns of the different hemoglobins will guide us to the diagnosis. If we have a patient with a borderline or a range between 3.5 to 4%, and a lower hemoglobin F, we have beta thalassemia trait. A patient who have a borderline with hemoglobin F higher, so here we will suspect the beta thalassemia, and a patient who have a spike of hemoglobin H in the HPLC and a lower hemoglobin A2, this will suspect the hemoglobin H disease. Then the detection of the different hemoglobin and E, S, and C, which has been detected by HPLC with the presence of the A2 will guide us to the other structural hemoglobinopathies. So the clinical presentation of these patients will differ. The TDT patients are more likely to be diagnosed lower than 2 years. They have more severe degree of presentation, while the patient with NTDT, they are having milder to severe anemia. The presentation of splenomegaly is mild to severe, the jaundice and the deformity, and also the growth retardation. The HP level also is a place where you will compare the patient with non-transfusion dependent will have a more better hemoglobin level, fewer nucleated red blood cell and reticulocyte less than 10%. So there are many, we have to keep in mind, there is many modifiers to the disease in the thalassemia. So in beta thalassemia, there are primary and secondary and tertiary modifiers according to the degree of the alpha and beta chain imbalance and the broad diversity of mutation that we have, with the coexistence of the alpha thalassemia and the different gamma chain production, which Dr. Christina have tackled on. Also, hemoglobin E and beta thalassemia will have the same primary and secondary modifiers, but there are others changes that with the advancing age with EPO production or the virus infection, it will lead to ameliorating or accelerating the severity of the disease. Now, the Mahidol score, which is one of the, which is a scoring system that have been created to evaluate or score the severity of the patient with hemoglobin E beta thalassemia. And this score will have different criteria. According to the presence or absence of these criteria, the score will be if it is less than mild to moderate or severe according to the score. Alpha thalassemia also will have the primary modifiers, which we have in the hemoglobin H disease, and it will depend on the form of the deletion or that the patient will have. And the secondary modifiers regarding to the co-inheritance of beta thalassemia trait and the role of alpha hemoglobin stabilizing protein. So talking about the pathophysiology, that with we have the impaired, there will be impaired alpha and beta globulin chain, which will affect the cell production and ineffective erythropoiesis, leading to the different complication and producing a hypercoagulable stages with the effect of the iron overload that will lead to different endocrine and thromboembolism event. This slide shows you the common complication that is seen with the different transfusion thalassemia, but what are the common complication here? We have the pulmonary hypertension, the thromboembolism, osteoporosis will be there. The more common, we have the liver fibrosis, the risk of hepatocellular carcinoma, and the gallstone, the extramedullary hematopoiesis, which is more common seen in non-transfusion dependent thalassemia. Talking about the iron load, which is seen also in these patients, even if they are not receiving the regular transfusion or requiring because of the ineffective erythropoiesis, and in part is inappropriate low hepcidin levels that will lead to an increased intestinal absorption in these patients and leading to the iron overload. Thrombosis is one of the complications or the hypercoagulable state of this patient, where it is a multifactorial related to pathological red blood cell with increased thrombin generation, also due to the iron overload leading to increased endothelial injuries and platelet abnormality with thrombocytosis and chronic activation with increased adhesion and aggregation, lead to the increased risk of these thrombosis. And it is mostly, there is increase of 20 times risk in patient with post-splenectomy. I'll just tackle also the importance of transfusion therapy in these patients. The time of initiating this transfusion in this patient is a bit challenging decision, because the indication will not be based only on the hemoglobin level only, but also on symptoms of the anemia and the complication related to these patients. So the first indication by TEF guidelines is that the transfusion will be mandatory in acute stress conditions, where the patient have a hemoglobin less than 5 grams per deciliter, in patients who are undergoing surgery, pregnancy, or having infection. There are other indications in the pediatric age, where we have a progressive changes that been identified in this patient, where we have a declining HP level in conjunction with the profound enlargement of the spleen, growth failure, and most important is the height as an indicator, poor performance at school, diminished exercise tolerance, failure of secondary sexual development along with born age, sign of bony changes, frequent hemolytic crisis, especially in patients with hemoglobin H disease, and poor quality of life. The last indication is the presence of complications. So transfusion may be considered for the primary prevention in this high-risk population and management, and secondary prevention for the following complication. So a patient who have a thrombotic or cerebrovascular disease, a patient who develop pulmonary hypertension with or without secondary heart failure, or a patient with extramedullary hematopoietic pseudo tumor. So this is my last slide. This is a concise for the how to treat this patient. The main problem in this patient is the anemia and the iron overload, and balancing between the treating the anemia and the complication of exaggeration the iron load will be should be a clinical taking in the clinical perspective. The modality are different. We can treat the anemia with blood transfusion or using a new drugs or hydroxyurea or a new critical clinical trials. It will be depend on the assessment of this patient and looking into the severity of the disease. I just want to conclude that non-transfusion dependent thalassemia patients are still need to be earlier diagnosed, because this will establish a good preventive care, and also will give us the time to appropriately mitigate this risk. And as you know, unlike the patient who are transfusion dependence and beta thalassemia majors, they have a frequent follow-up. They have a well-designed transfusion therapy, but patient with TN, the non-transfusion dependent, may not be easily identified, and hence they are not appropriately managed or appropriately monitored. So the recommendation is to have an engagement of primary care providers in this area with a high prevalence, and initiating the development of new guidelines for a national or regional to foster the advancement and better management of these patients. So with this slide, I will conclude my talk, and I'm happy to receive any questions. Thank you.
Thank you so much, Dr. Amira, for covering this very important topic. Yes, I agree with you that patients who are non-transfusion dependent thalassemia, they are internationally less cared for, or they don't have structured treatment flow chart. This is why some patients they achieve or they receive better care, others don't. It depends on the treating physician. Okay, with that, thank you so much, Dr. Amira. We move to the next speaker. Now, there is change in the schedule. As Imelda Kelly, she did her presentation yesterday. So our next speaker is Dr. Mona Addabagh. Dr. Mona Addabagh is the chair of the Department of Pediatrics at King Abdulaziz Medical City, Jeddah. She specializes in pediatric infectious and in transplant infectious diseases, and is an associate professor at King Saud bin Abdulaziz University for Health Science. Additionally, she directs the continuous professional Development Program at the University's Deanship of Postgraduate Education. Please, Dr. Mona.
Yes, thank you very much, Dr. Najat. يعطيك العافية. I just want to make sure if you see my slides. Can you see my slides?
Not really, no, Doctora.
Not really? طيب.
Yes.
Can you see my slide now?
Yes.
Okay.
Yes.
بسم الله الرحمن الرحيم. Greetings everyone. والصلاة والسلام على سيدنا محمد وعلى آل بيته الطيبين الطاهرين. I'd like to thank Dr. Najat and all the organizing committee for inviting me and for giving me the opportunity to participate with you today. What I'm going to talk about now, I'm going to bring the perspectives of infectious disease doctors with patients with hematological disorders and those with neutropenia. So what I'm going to talk about is management of febrile neutropenia from risk to recovery advances. So the objectives of my talk are to present an updated evidence on preemptive therapy for pediatric febrile neutropenia, to illustrate the evidence behind a step down to oral outpatient treatment in pediatric patients with febrile neutropenia, and early discontinuation of antibiotics in febrile neutropenic patients, and to illustrate the recommendations for initial pediatric febrile neutropenia management and prolonged febrile neutropenia management. So to start with, we have to understand what is the meaning of febrile neutropenia. So febrile fever basically means a single oral temperature measuring 38.3 degrees Celsius, or temperature of over 38 degrees sustainable for over 1 hour. So this is the first part. And the second part is neutropenia, which is defined by an ANC count of less than 500 cells per cubic millimeter, or an ANC that is expected to decrease less than 500 cells per cubic millimeter during the next 48 hours. So to say febrile neutropenia, we have to have both parts fulfilled, the fever and the neutropenic part. So we have to understand that febrile neutropenia occurs in around 10 to 50% of patients with solid tumors and up to 80% in patients with hematological malignancies. There is 30% risk of invasive bacterial infections in the immunocompromised subjects, with 10% associated mortality, and 10% is quite high number. So a neutropenia can be defined into profound, where the ANC count is less than 100 cells per cubic millimeter. Prolonged neutropenia, defined as neutropenia beyond 7 days. And persistent fever and neutropenia is the persistent fever in neutropenic patients after 4 to 7 days of broad-spectrum antibacterial coverage. So it's important to differentiate between these definitions, because not all persistent febrile neutropenia are prolonged neutropenic patients, okay? So the classification of risk for infections with fever neutropenia is differed by the Multinational Association for Supportive Care in Cancer. So they classify them into high-risk people if their classification for high risk index is over 21, and they have profound neutropenia with a prolonged duration beyond 7 days, or where their ANC count is less than 100 cells per cubic millimeter. Furthermore, patients are considered high risk for infections if they are clinically unstable, if they have medical comorbidities, hepatic insufficiencies, renal insufficiency, poor functional status, advanced age, and disease type, together with, of course, the intensity of chemotherapy. Patients with classification risk index of less than 21 are considered low risk, and those with lower degree and severity of neutropenia, less duration, are also considered low risk, and those who are clinically stable with no active comorbidities are also considered low risk. So these are all important factors that we consider whenever we manage any patient. And this plays major role in our initial antimicrobial therapy. So let's talk about empirical antimicrobial therapy. We all know that whatever we give has to be something that has good anti-pseudomonal activity, as those patients are in hospital for so long, and they are at very high risk for pseudomonas. So let's look at that study. This study is published in 2021. It's a systematic review and Bayesian network meta-analyses comparing the efficacy and safety of different anti-pseudomonal agents for pediatric febrile neutropenia. The study included 8 randomized controlled trials with over 2,500 patients. The primary outcome of interest was treatment success without modifications of antimicrobial, and secondary outcomes of interest were adverse events, all-cause mortality, and development of new infections. So this study basically here, as you see in this table, this summarizes the different anti-pseudomonal agents that were used, including cifepim, meropenem, piperacillin, tazobactam, ceftazidime. So all different anti-pseudomonal agents, and comparing them together. And if you could see, basically, so this is, for example, cifepime versus tazocin. So it shows you that there is no difference. And this is cifepime versus meropenem, and piperacillin versus meropenem, showing you no difference. So basically, the table shows you that if there is no if we talk about efficacy for treatment success without need for modification, there is no difference between the different antimicrobial agents, anti-pseudomonal agents that are being used. However, when they did the Bayesian cumulative probability risk for efficacy of anti-pseudomonal beta-lactams without modifications, you can see in this curve, meropenem had the highest probability, cumulative probability for treatment success compared to the different anti-pseudomonal agents. Furthermore, in this figure, you can see the different anti-pseudomonal agents, and they split in this figure the different outcomes. So looking here as treatment success without modifications, and as you can see, the violet purple is meropenem. So the meropenem showed the best outcome in regard to treatment success without modifications. They looked at as well the risk for development of new infections, and as you can see, meropenem and tazocin had the highest and the best outcome regarding the prevention from development of new infections, whereas cifoprazone and sulbactam and tazocin had the highest and best outcome for lowest cause deaths. And as you can see here, ceftazidime and meropenem has the lowest rate for adverse events. So this is another study that looked at the carbapenem versus alternative beta-lactams. They compared, now we said that carbapenem had the best outcome in regards to treatment success. But in that other study, they did break down the data looking at carbapenem versus alternative beta-lactams monotherapy or alternative beta-lactams in combination therapy. So this study included 50 randomized controlled trials involving over around 11,000 participants, and this is I know that this is a very big forest plot curve. However, maybe it's worth looking at the final outcome. So we're looking here at the treatment success without modifications. You can see that there is superiority and significantly better treatment success with the use of meropenem. So let's look at this. I'm breaking down the next slide, breaking down this curve based on the different interventions being compared. So this part, basically, it compares meropenem versus beta-lactams alone. So if you look at meropenem versus beta-lactam, you can see now our outcome of interest here is success without need for modifications. So meropenem alone versus a different beta-lactam showed significantly better success without modifications. Similarly, if we look at meropenem versus a beta-lactam combination with aminoglycoside. So let's say any beta-lactam with aminoglycoside versus meropenem alone. Again, meropenem shows a significantly better outcome. And here we're looking at meropenem combination with aminoglycoside versus beta-lactam, showing no difference. This next part, I'm gonna address the next part. Next slide. So this is looking at imipenem, not meropenem. Imipenem versus beta-lactam similarly shows better outcome with imipenem compared to beta-lactams. And when we talk about imipenem here at the bottom, imipenem versus beta-lactam combination with aminoglycosides, again, significantly better outcome with imipenem. Similarly, further comparison was done for the use of imipenem versus beta-lactam combination with vancomycin, showing better outcome with imipenem. Although it was only one study included in this comparison, and the last comparison was for imipenem combination with vancomycin versus beta-lactam combination with vancomycin. Only one study was included and showing no difference between the two groups. The last part here is the imipenem combination with aminoglycosides versus beta-lactams alone. Again, imipenem gets the better outcome, and imipenem combination with aminoglycosides versus beta-lactam combination with aminoglycosides, only two studies included, showing no difference. And this is the overall comparison showing that treatment success without modifications is best with the use of any carbapenem agent. So meropenem similarly showed similar risk of adverse events versus beta-lactam. So if we talk about adverse events, meropenem was similar to other beta-lactams. However, imipenem was related to higher risk of adverse events compared to beta-lactams. And this is where we have to step back and think wisely and say, okay, if imipenem is associated with higher risk, then we have to think of risk versus benefit. And there was no significant difference between carbapenem versus beta-lactam monotherapy or in combination in relation to our side effects. So next part I'm going to talk about is the step-down therapy. So this study was done in children with low-risk febrile neutropenia. It's a meta-analysis systematic review. What they did, they included 37 studies with over 3,000 episodes of fever neutropenia. The study included 13 randomized controlled trials and 24 prospective cohort studies. So the outcome of interest here was treatment failure. And treatment failure is defined as any of those, either persistence of the infection or worsening or recurrence of the fever or infectious organism, need for antibiotic modification, new infection, readmission or admission to the critical care area, or death. So these are all considered in the outcome of interest, which is treatment failure. So basically, what they found is, so this is the rates of treatment failure in pediatric low-risk febrile neutropenia if we use the step-down therapy. So step-down therapy here was used as two different modalities, either studies treating patients entirely outpatients, so the step-down therapy included treating them as outpatients, or patients that use step-down therapy in the low-risk patients if they have fever deference within 48 hours, so they send them home on oral antibiotics. So basically what happens here, we can see that the risk of failure, the rate of failure in those patients for entirely using outpatient therapy was around 14%. It happened in 14% of the cohort studies, and it happened in only 2.2% if we used studies after stepping down after 48 hours of inpatient care. So failure rate was 14% if entirely using outpatient therapy, and failure rate was 2.2% if we use 48 hours of inpatient and then discharge patients. We have to also highlight that reduced intensity therapy for low-risk febrile neutropenia is safe with low rates of treatment failure. Furthermore, they looked at the clinical trials. So we said that there were 13 clinical trials. And in the clinical trials, they found that the odds for treatment failure without patient treatment was around the odds is 0.98, so it was not different from those who did not receive step-down therapy or outpatient therapy. And furthermore, the odds ratio for step-down with oral modification after 48 hours was also not significantly different than people who receive entirely full IV therapy. The proportion of ICU admission or death was 0.1% in these studies. This is a study that was published actually looking at the safety and efficacy of step-down to oral outpatient treatment versus inpatient antimicrobial therapy treatment in pediatric patients. I included this trial because this was published actually after the systematic review that I just presented to you now. So this study was published after, and it actually supports the same evidence that I just shared with you. The study included 117 cases were randomized, 60 to outpatient group and 57 to continuous inpatient treatment. The treatment group were randomized after 48 to 72 hours to oral step-down therapy. So basically, they received cefepime as inpatients and cefixime orally as upon discharge. 100% in the outpatient group and 93% in the inpatient group had favorable outcome, for which this study basically supports the use of step-down oral therapy. And the mean duration of antibiotics use was around 4.1 days in the outpatient group and 4.4 in the inpatient group. Here I'm going to come and address another interesting, and I think it's a very important topic to all hematology oncologists. So here we're talking about the early discontinuation of antibiotics for febrile neutropenia versus continuation until neutrophil resolution. We all know that all this previous experience in patients with fever neutropenia is that you give them antibiotics until neutrophil recovery. But now the study, this meta-analysis published in Cochrane database, they looked at whether there is any room for early discontinuation of therapy if the patient is clinically well, he is afebrile, cultures negative, and I have to highlight on culture negative febrile neutropenia, and the patient is clinically well, yet neutropenia persists. So this included 8 randomized controlled trials comparing total 662 distinct febrile neutropenia. And here I'm talking about high neutropenic patients. Okay, the studies included adults, children, variable designs and criteria for discontinuation of antibiotic in both study arms. And they included, as I said, those with microbiologically confirmed infections, and primary outcome of interest, 30 days or end of all-cause mortality. So the outcome was all-cause mortality. So what the study showed. Basically, the study said the randomized control trials, and as you can see, people received short antibiotic therapy discontinuation versus that followed the call of continuation between the two study arms. Furthermore, they looked at versus discontinuation of anti effect on total days, and as you can see here, that this is very short therapy or long therapy. So here about the total days, and the they addressed was the effect antimicrobial resistance. This is very important outcome for infectious disease doctors, and it shows you that basically there was no all studies addressed that part, but they showed no difference between the two study groups. Furthermore, early versus late discontinuation of antibiotic effect on bacteremia, on any, whether if we discontinue antibiotics early, whether those patients develop bacteremia. Again, it shows no significance. However, there was a little bit of trend with favoring long-term therapy, but this was not statistically significant. I need to highlight that they did state very clearly in that study that we could not make no strong conclusion on the safety of antibiotic evaluation before neutropenia resolution among people with those are all high risk, high risk febrile neutropenia based on the existing evidence and its low certainty. As we see, the problem here is that despite we're talking about 7 studies, the sample size is still not very big, and the certainty was not so strong. However, there is currently available evidence that supports it, but maybe it needs to be investigated further. What if the febrile neutropenia stays longer despite broad-spectrum antibiotics? For giving antibiotics and fever continues. Now that is the time where we have to think of fungal infections. So who are patients that are considered at high risk for fungal infections? There are high risk group and there are low risk. High risk patients for invasive fungal infections are recipients of stem cell transplants with AML, the relapse ALL protocol, 7 days. Group, we have the group for mold infection specific, okay? And those are the people where neutropenia is more than if we start antifungal therapy beyond 11 days, we can reduce this mortality rate to 41.
Dr. Mona, sorry, you have a poor connection. You need to share your slide again.
Again, this is how it appear on CTM. Oh, okay. I'm going to close my camera, maybe. Can you see my slide? Hello?
No, we
Still,
don't
we
see your
cannot see
slides,
your
Doctora.
slide.
Hello?
You have poor connection. You have to make sure from stability of your internet, please. We see it now.
Doctora Mona?
So I tried to log out and log in again. So can you see my slides now again?
We don't see your slide, Doctora.
Now?
Yes. Yes, we do.
Now you can see it? Great, great. So this is how fungal infections appear on CT.
Dr. Mona, your connection is not stable. It's interrupted.
As Dr. Mana has technical issues, we'll conclude now. So distinguished colleagues, esteemed guests, and dear friends, as we conclude the 6th International Pediatric Hematology Conference, I wish to express my sincere gratitude to each of you for your active engagement, dedication, and invaluable contribution throughout these past few days. Together, we have examined significant advancement in pediatric hematology, from pioneering gene therapies and CRISPR technologies to enhanced strategies for managing complex blood disorders. The insightful presentation, rigorous discussion, and collaborative spirit demonstrated here stand as testimony to the strength and unity of our global community. Over the course of this conference, we have shared groundbreaking research, exchanged critical clinical insight, and fostered new international collaboration. The knowledge and connections gained provide a robust foundation to further transform pediatric hematology care worldwide. However, our work doesn't conclude with this gathering. I encourage each one of you to carry forward this momentum, whether by advancing innovative research, implementing best practice within your institutions, or advocating for increased awareness and equitable access to care in your respective regions. Let us reaffirm our collective commitment to being catalyst for change, ensuring that every child affected by hematological disorder receives the highest standard of care and the promise of healthier future. While we celebrate the remarkable progress achieved, we must remain mindful that the journey to alleviate suffering and improve outcomes for children with blood diseases is ongoing, and it is incumbent upon us to translate the ideas, partnership, and the knowledge shared here into tangible actions, propelling research and enhancing clinical care and promoting health equity worldwide. I'm deeply inspired by the passion, expertise, and the compassion each of you has demonstrated. It is this unwavering dedication that drives hope and innovation, shaping the future of pediatric hematology. I extend my heartfelt thanks to our keynote speakers, presenter, organizers, and all participants who have contributed to the success of this conference. Your collaboration and vision are the pillar upon which we will continue to build a healthier future for children globally. We look forward to welcoming you in person at the 7th International Pediatric Hematology Conference, where we will continue advancing our shared mission. Thank you once again for your dedication and participation, and goodbye for now, and see you inshallah next year. So we're done.